Please tell us before 2 seconds.
Dear doctors, we are live.
Good evening, everyone. This is Dr. Lalit Maini from Delhi Orthopaedic Association, and a very warm welcome to the Sunday evening webinar. Delhi Orthopaedic Association has been doing the Sunday evening webinars for 3 months now, and they're gaining a lot of popularity. Today's turn is for a grand round on proximal humeral fractures. This is actually the fourth grand round which we're doing for this year. We had one on elbow, on tibial plateaus, on calcaneum, and now it's on proximal humerus fractures. I'm sure it's going to be a very good interactive evening where we'll clarify lots of thoughts on proximal humerus fractures. We have a very great dynamic, energetic faculty from all around, and they have a combined experience of over 100 years on shoulder surgery. So there are going to be lots of viewers. We have normally around 1,500 to 2,000 viewership in the evening. The show is supported by OmniQuirus, and it is also co-hosted on OrthoTV. We've already crossed around 20,000 of viewership in the last few events, and we've placed around 50 videos on the Delhi Orthopaedic Association library through these events. So we'll not delay you further. The moderators for today's evening are going to be Dr. Maheshwari and Dr. Shashank. I would hand over to Dr. Shashank Misra to introduce the faculty and take this today evening's webinar further.
Hello, I hope I'm audible.
Yeah.
Okay, so good evening, friends. It's a great honor to be with you today. One of the good things when you have a galaxy of well-known faculties, they don't need much of introduction. I have Dr. Maheshwari, who you all know, who is my co-moderator today. You must have read his book. He's the same J. Maheshwari of Maheshwari's Essential Orthopedics. No introduction needed there. We have 6 speakers today who will be talking about proximal humerus fractures through the case presentations, and you can put your questions in the chat box as we have been doing in the last couple of weeks. What we are trying to do today is discuss for 30 minutes each all possible, not all, most of the treatment options of the proximal humerus fractures. But before we start that, we will have Samir, who is my co-PG. He was my co-PG in 1999 in Lady Harding and UCMS. Samir, he's a now senior specialist, and he will be talking about what to look for in X-rays and CT scans to decide about the management. After that, Vivek Pandey, he's the professor of orthopedics. Don't be surprised, I'm not making a mistake. He is now the professor of orthopedics in Kasturba Medical College, Manipal, who will be touching upon which fractures can be treated conservatively. After that, we'll have Ramakant. He's the senior consultant shoulder surgery in Medanta in Delhi, followed by Dr. R.K. Pandey, the boss of Leicester Shoulder Trauma, about technique, that is percutaneous pinning, where to do, where not, what to look for. After that, we will have Nandan Adla. He is from Hyderabad. He will be talking about interlock nailing. Yes, interlock nailing is gaining fame now for last couple of years with the introduction of new nails, and he will tell us more about it. And in the end, we will have Dr. Kapil, all the way from Aberdeen, who will be telling where not to fix and when to do arthroplasty in these cases. I hope you know how to ask your questions. Please put them in the chat box. Me and Dr. Maheshwari will try to take as many questions as we can. I request all my speakers not to exceed their initial quota of 15 minutes so that we can have equal discussion time of about 15 minutes after their presentations, which is only cases, no lectures. Over to you, Samir.
Thank you, Shashank, for the introduction. And let me begin. I'll start my sharing of my PPT. Yeah. Okay. Is my screen visible to everyone?
While he's putting his presentation.
Shashank, yes, can I start? Is my screen visible to all? Am I audible?
Yes, your screen is visible. Please go ahead.
Okay.
Please go ahead.
So, yes, good evening to everyone, to all the faculty, to all the audience, to my friends, colleagues, and respected seniors. Thanks for inviting me. I hope I'll contribute to this prized seminar. So my talk is on X-rays and CT scans in proximal humerus fractures. Okay, so I remember Shashank, as the hard taskmaster that he is, he very categorically told that no lectures, please. So I'll start with the case and go forward from it. Well, a case is of a 70-year-old lady, and she has a fall in her bathroom and suffers a proximal humerus fracture. And this is the radiograph of the same. Well, she suffers from various comorbidities like diabetes mellitus, hypertension, Parkinsonism, and osteoporosis, which is expected in this age, 70 years old. So what would be the plan? Well, she was taken immediately to the neighboring corporate hospital at Delhi, and she was advised an open reduction fixation procedure. So my question to everyone would be, what would you like to do in such a case? Well, since we are not live audience and, so it takes time if everybody starts speaking. So I believe somebody would say CT scan. Well, then I would put a caveat in it that it was a peak Corona time. It was last year. And it was lockdowns all around and family was not comfortable to risk it all, taking the injured patient all along and then amidst thick of Corona. So, and as it happens, commonly, at least in India, that I got a call. The son is a good friend of mine. We play tennis together. And he gave me a call Sunday morning and asked me what to do because he was advised surgery and Corona was there. He was very troubled. And so what did I do was, this is the original picture that I took of myself at my home on Sunday. And I asked them to get another X-ray done and in this position. Well, this is in anatomical neutral position. As Dr. J. Maheshwari calls it, a beggar position, asking for alms. So I asked them on WhatsApp, please do another X-ray and send it to me. And this is what I got. So this X-ray, as you can make out, is much better than the last one. That is this one. And you can see that in this X-ray, the new X-ray, you can see the profile better. You can make out the fractures. At least it's a 2 or 3 part. If this is the GT, displaced GT, surgical neck, and this looks like maybe a 3-part fracture and maybe possibly some combination medially. So this is what I got. So now what? Now we have a good X-ray in our hand, and now how do we decide what to do about it? Why I want to show you this is that once you have a good X-ray, well, then everything starts. Your mind starts running, you know the treatment very well. As a trained orthopedic surgeons, there you start. And so I advise a conservative treatment, and this is what I got after 4 months. So I'm not going to do conservative treatments because this is being taken by another of my colleague later on. And this is after a few months, after 6 months, well, she is a sick patient, Parkinsonism and all, and this is a painless movement that she's got without much ado. All right, so the idea was that imaging the shoulder after trauma is key in any triage if it's a major injury and decision making, and better imaging, of course, will do wonders to how you decide about treating the patient. Well, what you need as a surgeon when a patient arrives first are few radiographs, what we call as a trauma series. Well, trauma series, one is a true AP view. Now, true AP view is a very different than AP view. If I take you to the next slide, well, this is the AP view. A surgeon is standing with the right shoulder, which is injured. He's standing against the receptor cassette, and the beam comes at right angles, but actually it is not right angles because the scapula is not at right angles of the beam. It is a bit oriented at an angle. So unless you orient the patient and turn the patient around 45 degrees, 30 to 45 degrees, and make it vertical against the beam, you will not get a true AP. So again, this is a true AP on the right, and this is just an AP. What is the difference? You can see in true AP, you can very well see the joint, opened up joint. You can see both the margin, the anterior and the posterior glenoid rims overlapped. You can see the clavicle very well, acromion, nothing is overlapping. While here, you cannot see the joint properly, you cannot see the rim properly, and neither you can see the GT so well. So it is important that we do a true AP view. And this is a norm for all shoulder surgeons, that they always want this kind of an X-ray, which is looking very well with most of the anatomical structures very well visualized. So this is one true AP view that we need. And there you go again, and then you see all the kind of fractures. I'll show you later. Just to mark it for the beginners who are watching this, well, you mark it, you have an acromion, and you have the glenoid cavity, the surgical neck, the anatomical neck, the clavicle, and everything has to be right in front of you, looking at you, without any overlappings and without any shadows, and then you can decide on your treatment plan. Well, this is another example. This lady arrived only yesterday in our outpatient department, and she had a left shoulder injury. There was some swelling on this limb also. And well, this was the first X-ray that was taken by the technician. So this is what we got, the head of the humerus looking backwards. It is already retroverted and more retroverted now. And then when you do in this position, the neutral position or the beggar position as we call it, well, there you go, and you find a nice X-ray, and she had a mild undisplaced fracture over there of a GT, and otherwise she was just fine. So this is the way you take it. This is not to be done, so I'll put a cross here. This is not to be done like this, and this is the right way, and maybe a little tilt was also needed. Next, in trauma series X-ray is the axillary view. Now, this is how the axillary view is taken, patient lying down and the beam going through the axilla, and this is what you get. If you label it well, you have the glenoid, you have the acromion. This hole is the acromion, which is overlapping the head. You can see an AC joint behind the head, and here you see a GT and the LT and the clavicle, and this is the kind of view you get. What do you see? Well, you can see head splitting fractures in coronal plane. You can see glenoid ring fractures. You can see glenohumeral joint subluxations or dislocations. You can see great tuberosity fractures, and you can also see Hill sacks and Bankards in case of dislocations. So this is actually lateral view, which is again needed. So this was the second X-ray. The first I had shown in detail was in true AP view that you have to get done. Another example, a pelican sign is seen like this when you have an axillary view. Pelican sign is seen in split type 2 of the head of the humerus. And then you have a scapular Y view or a lateral view. Well, scapular Y view is when you orient in a way that the scapula is lateral and you have a very good Y-shaped, that's why it's called a scapular Y view. You have Y-shaped shape of the bone. You have the upright spine. You have 20% acromion, which is behind the spine. You have clavicle, which is not overlapping any structure. And you have, if you have any fracture of the acromion of coracoid or proximal humerus, you can see it very well. You can see dislocations very well in this particular view. So this is a scapular Y view or a lateral view. And we need all these three X-rays to come to some decision making in a treatment plan. Well, alternative ways. Well, these are the plans, but then sometimes the patient is injured. Now, this lady has a fracture, of course, in this figure, and then this is a Welper view which can be taken, and by the leaning backwards, you can have a end-on picture of the radiograph. This is another one, patient lying down. If he cannot stand, has injuries on the lower limb, this can also be taken like this. So these are alternative ways. These, another way where the technician is supporting, you can have a lateral view, even by lying down, patient may not just stand, the technician is supporting with her hand, the upper torso, and you can have a lateral view. And this is again the kind of Welper view, but abduction. So now I'll give you some examples and show you some images. So this is a head split fracture, which is type 1. You can see this is a fracture here, which extending to the articular margin. And this is the axillary view. And this has been treated by conservatively, and this is healed very well. And in another view, if you see, this is the fracture. This is a split fracture of the type 2 variety of the head. And this is a multiple fragmentary portions lying here in the image, and you can see it was fixed by a Fellows plate and also an interfragmentary screw. Now, mind you, this was an X-ray, while this is a CT scan. So the surgeon always has a choice. This was easy, where you could see an undisplaced fracture, and you can take a call that you might not need a CT, or if CT is not freely and easily available in your vicinity, then you can treat the patient without a CT. So not a mandatory one. But in certain fractures where you see there is displacement, and you can imagine that there could be further more fragments which would decide a kind of a complicated surgery, you would need a CT scan. So this is what, here comes the role of a CT. Now, again, another example. So this is an articular split fracture in a 48-year-old lady, a biker. And then this is the radiograph. Now you can see there's a shaft fracture, there's a split fracture of the head, and then you still cannot make out clearly. Now there comes the role of the CT, a 3D CT or a 2D CT, depends on you. Well, the 3D CT gives a clear picture. There is a disruption of the articular surface of the head, and you can see a CT scan clearly visible, much more visible than one in radiograph. And here you go, and you know how to treat this. And this is a 2D CT scan of a 60-year-old male, and he has got 3-part fracture, not actually a 3-part, near 3-part, but head which is split into 3 parts. So this is a split head fracture, and CT scan is differently needed for such fractures, where you specifically see the head split fracture. Now, we all know NEARS, but since I'm talking about, and in the rest of all the lectures, you would hear about 1 part and 2 parts, so a glimpse would be necessary here. So we know NEARS classification way back of lesser tuberosity of GT, of articular and humeral shaft. A fragment is considered displaced if it is separated more than 1 centimeter or angulated more than 45 degrees. This is by definition. Some surgeons, over a period of years, they take angulation of around 30 degrees as displacement. So, well, this is another classification. You can all read about it, nothing new in it. So this was just to give you an idea, to orient you about my talk and the talks coming later on. What are the indications for surgery? Well, my talk is not on surgical indication, but this is necessary because, after all, this is why we get the X-rays done. This is why we get the CT scan done, because we have an idea now that when to operate and not to operate. So we have to see the displacements of the head. We have to see the angulation of the tuberosities or the parts. And we have to see how much they are displaced. If they're isolated tuberosities, if they are displaced more than 5 mm, then of course this is an indication for surgery. So this is what is needed. When we talk of the X-rays, I've talked about the trauma series, the AP view, I've talked about the axillary and the scapulolateral view. I must also talk about the X-ray taken via C-arm in the OT. Well, then the preferable method for anyone who's initiating into these surgeries is that the C-arm should come from the head end. And if you operate in this position, C-arm can come from the other side also. But if you take this, the position of the patient and the C-arm, well, then you can have a good AP as well as an axillary lateral view, which should also be taken during the surgery. So this image was specifically put, to make you understand how best you can do a surgery with a C-arm control in your operation theaters. Well, a little bit of fracture morphology, because if we keep on talking, but if you don't have a picture in your mind what we're talking about, well, you should understand that if there is a fracture, whenever it happens, there are displacements. Now, how do displacements happen? First, the pectoralis major, which is attached here, displaces the shaft medially and anteriorly. Then comes the rotator cuff, and the tendons there rotate the GT. This is the GT, and during the displacement of the fracture. And this, am I audible? Yeah. And this is important because this is where you look for the GT, because you know this is how the displacement happens. And subscapularis attached anteriorly will rotate the articular fragment along with the LT does an internal rotation of the fragment. So this is important. Whenever you consider an X-ray, you should have the morphology in mind. And whenever you go for the surgery, you should have a planned way wherever the fragments are placed or displaced. Now, this is a view to substantiate my point. Well, this was a surgery done by my friend of mine. Well, here you go. And this was not seen on the table because I believe the axillary view wasn't done at that time. After the surgery, well, this radiograph was taken and the missing piece was found to be lying there. If you can go to my last slide, I told you that the SSP, ISP, the rotator cuff tendons rotate the GT externally and backwards. And now you know the GT has to be here. So, of course, it was fixed back and nicely done. The patient was well. But this is important when I tell you that the axillary view on table inside the OT is necessary so that you don't miss these points or the fractures rather. Now,
Samir, how long are you going to take?
Sir,
if lectures about surgery in further ahead.
Great. So then I just wind up and just give me a minute and two, and I'll wind up.
Right.
All right. So again, this will be taken up by my colleague later on. But why I'm showing this specifically is because this is why the CT scans are done. To, see the medial hinge and medial hinge later on will be talked a lot about in all this seminar which is coming up. So get ready for that. So this is why we get CT scans done to look for these kind of problems, no medial hinge. And if you know medial hinge, this is going to happen. I'm going to pass it quickly. So again, CT scan, you can see displacement of fragments very well. You can see rotation. You can see status of head and articular surface and related bone loss, etc. In a nutshell, makes life easy. These are a few examples. So just skipping them quickly. If you get CT, you can have a better spatial look and all the fragments right in front of you. CT scan is especially needed in a head split fractures. So type 1, 2, 3, and 4, well, you accordingly, whether conservative and type 4, you might go for replacement. Well, you need a CT scan. And this is where the base is laid for all the treatments ahead. Again, I'm talking about, well, I believe my colleague will talk about it, so I'm missing this. Then when do you decide that whether to replace or to conserve or to operate? Well, I'm skipping this now. So this is the humeral head again, and as you see, multiple fractures and eggshell hair, and has been treated by RSA. So this is what it is. Again, just an example, just a visual kind of stimulation for your mind. So this is again taken care of. Well, this is very important slide, but again, this would be taken off, and this shows everything. What are the criteria for operating? What are the criteria when you decide, I won't fix it with Fellows plate or whatever plate or by nail, and I'll go for hemiarthroplasty, and when do I go for total replacement? Again, this will be taken up, but this is why we do all these X-rays and all these CT scans serially one by one to get to a planned method of further treatment. Well, thank you very much, sir. This is what about all the X-rays and CTs.
Yeah, thank you. Thank you, Samir. If you could unshare. You have very started the inning, and I'm sure there are already a lot of questions on the chat box here from the faculty, because we are talking about, as you know, this is a PG class, or I would say class for general orthopedic surgeons, and we have to give very clear messages. And I can already see a lot of controversy on the chat box from the faculty. So maybe if I can summarize the controversies coming up and also from your lecture to make it very clear for the audience. Number one, you must have two X-rays, AP of some kind. I'm not going to the detail. AP, possibly a bagger position or a neutral position, not a sling AP, what I call. That's because they come in sling and they take an X-ray. That's not done. And some sort of lateral. It is difficult in a trauma patient to do axillary, but some sort of lateral. And my
Maheshwari?
Yeah.
Can you just elaborate on the AP again a little bit for the benefit of all the
picture? It is a AP in neutral position and not in a sling. Normally, the patient goes to the radiographer, and all these patients have an X-ray before they come to you, and it is taken just like that randomly, and that is what confuses you. Exactly what Dr. Samir showed even in his presentation. So, first thing that you should do is you should see whether the X-ray has been done properly, particularly the AP X-ray. Then if you are confused, always have a lateral, more often than not, some kind of lateral. Again, in a trauma case, it becomes very difficult to do axillary lateral, but I'm sure a scapular lateral is no problem. Now, another message I want to give is do all X-rays standing. A trauma patient, you cannot ask him to lie down on the couch, get up again. It is too cumbersome. All shoulder X-rays of a trauma case should be done standing, full stop. In my practice, every time a trauma shoulder, only standing X-rays are done, AP lateral, whatever view you want to do, but only standing X-rays in a trauma case. So no hassle to the patient of lying down on the couch. So some kind of a AP, preferably a true AP or a whatever AP, but the arm should be in neutral position. That is a message. Some sort of a lateral wherever your patient is comfortable. These two X-rays are very important. That's what most of the colleagues on the chat box also feel. Now, a very big question in our society is where to do CT. Now, you can't do CT everywhere because it costs money, patient has to go here and there. So we have to have very clear concept about when to do CT. In my practice, if the GT is not affected, or if I'm not planning to take the patient for surgery, CT is not required. For example, if it is a type 2 fracture, just a standard AP and a lateral gives you good enough information to decide whether you want to operate or not. As soon as GT is fractured, I cannot make out whether exact, and GT is a very important part of the fracture. So that's where CT comes into the picture. Given a choice, I'll do CT in every case, but that's not possible. So we have to be a little more discreet about doing CT scan. Maybe I'd like comment from
Dr. Maheshwari, can I just interrupt here? So when you say GT is not affected, many times you cannot make out. Are you trying to say that as long as you cannot, or as you can clearly see the GT properly, there is no need of CT? Is that what you're saying?
Yes. I mean, all these statements are loaded, as you will know.
Yeah.
Like typical type 2, AP and a lateral is good enough. I have stopped doing CT for those. And maybe in those fractures, sometime if I need to do a surgery, I would do a CT, but more often, even in surgery, type 2 fractures, I've given up doing a CT. Doesn't give me any further information.
So for all the PGs who are here, it is very important to note what he's saying. He's saying CT is not important provided you have two good orthogonal views, mutually perpendicular views. If you just have a AP of one type and a badly done lateral on the other side, CT may be required. So CT is not required if you have two good mutually perpendicular views. As long as you have those, CT is not required in most of the cases. Please carry on.
Dr. Maheshwari.
1 minute, Dr. Raman, just let me finish. So another thing I would like to say is to interpret CT in an upper humerus fracture is not an easy job for an occasional surgeon. So it can more often than not, confuse you. So be very careful. CT is not the panacea. It should be done whenever you're in doubt to get more information. But I can tell you from personal experience, it's not that easy to interpret. Dr. Raman, all yours.
Yeah. Just what is this type 2 fracture you are referring to?
Surgical neck.
Type 2. Which classification is this?
Needs classification.
Oh, I mean, what he means is isolated surgical neck fractures. Okay.
Two-part fracture.
Two part.
Not type, but two-part. Okay.
You're right.
Yeah. Okay. Carry on, Dr. Maheshwari. You want to say anything else?
From the first talk, this is the kind of summary I got, and also I picked up some points from the chat box where there was a debate Obviously, I think axillary X-ray is not possible in a trauma situation, but scapular lateral is good enough. And from scapular lateral, if you really want an axillary, you are inching towards a CT scan then. Because technically to do a axillary lateral in a trauma is difficult. There are a lot of other views described in the book. I find it very difficult to tell my radiographer to do it occasionally.
Yes, can I interrupt?
Yeah, carry on.
In one of the meetings, I think Raman made a very interesting point. I think it was last year in ISIC. Raman, and I will need your comment on that. You said something about that if you want to look for a posterior subluxation or posterior angulation, don't go for anything else except either an axillary view or the axillary cut of the CT scan. Am I correct?
Correct.
Yeah. So I think that, can you just explain to the people again?
So the posterior dislocation can only be confirmed radiologically in an axillary view or axial cuts of the CT scan.
Okay.
I'm saying radiologically. Clinically, you can diagnose, but if it comes to radiologically, you cannot rule out, because scapular lateral will not rule out a posterior dislocation. It depends where the head of the humerus is looking at the position of the arm. But I do use scapular lateral for in a fracture situation along with an AP view. I don't use the axillary view for a fracture situation.
Okay.
Correct. I come back to my point of a good AP in neutral position. And message to PGs is that is the X-ray which raises suspicion of all kind. If you've done a AP in neutral position, that's what your eyes are used to seeing when you see a AP X-ray of the shoulder. If at all doubtful, don't hesitate, do the normal side and put them together. You will start seeing too much. If it is a posteriorly dislocated shoulder in a AP neutral position, it will show something is funny, the head is missing, and that will give you a cue to further investigation. So your AP in neutral position is a very key X-ray.
Are we done with it? Can we invite the next speaker?
No questions here further. And I think I've covered most of the points raised by my colleagues about what X-ray should be done. Unless there are some in the chat box from the audience. There are quite a few X-rays about comments about treatment. We'll take them later.
Maheshwari, can I ask a question and a clarification?
Yeah.
Regarding the AP, there were two things said. One is, of course, the neutral position of the arm. Other is angle, 45-degree angle to the plate. How important is that?
Yeah, so there is a big debate, and Shashank and me always have a debate. I think in trauma, you need a AP, simple AP, because everybody knows how to do it. Trauma is a everyday affair in every hospital. To actually do a true AP is more important in arthritis conditions, not, in my opinion, not in trauma. Trauma is a straightforward X-ray, just the arm in neutral position. I don't know whether other colleagues will differ on that.
I think we'll start a Pandora's box. I think let's stick to somebody's opinion. That's
okay.
I think that makes sense. Even if it is not through AP, heavens are not going to.
Sir, I fully agree with you. Only a neutral, like you say, like in your words, a bigger position gives the whole information. Yeah. I fully agree with you. But that is important.
So I coined this term beggar position because it's very easy to understand for the patient. I tell the patient himself that you have to get it done in beggar position. Now, no radiographer can cheat him. In our kind of situation, they don't listen to the patient. So I tell the patient, this is the position, this is called beggar position. They don't understand neutral position and everything like that. So I think it helps that way.
Dr. Pandey, Dr. Kapil, any comments? Can we go on to the next one? Vivek?
Yeah, I think boss has summarized it well. True, but yeah, I always feel when you are in doubt, you do the CT. When you can see most of the things reasonably well, I mean, in experience, whether he's a general orthopedic surgeon or he's a shoulder surgeon, so-called, most of the time you can make out, as boss was saying, that you know that, okay, this is reasonably undisplaced, not many lines around, you're going to manage it conservatively, then you don't need CT always. But whenever you are in doubt, and especially GT you can't see, or there are some lines which are going into the head, you're not sure, is it a split, or as what Raman sir was saying, are you doubtful about posterior dislocation? Are you missing it? Go ahead with CT, don't hesitate. This world will not forgive you of not doing it.
Totally, I totally agree with you. There are many times where a fragment, what looks like CT, could be a fragment of the head or a big fragment of the LT, and we make a mess of it, and it was missed, thought that is okay. And ultimately, we find out that it was a GT fracture was missed. I think my threshold, on contrary, Dr. Maheshwari, of getting a CT scan is rather low. After all, it is your reputation which is online. Nobody is going to forgive you just because you try to save 3,000 or 5,000 rupees for a patient.
Because everybody will say that I was the richest person on the planet. You never asked it.
Yep, that's Dr. Kapil, Dr. Pandey. What is your practice there? Can you just?
I feel one of the biggest problems we still have, people miss dislocations.
Yeah.
So many times, proximal humeral fractures, people miss dislocation. I have seen X-rays when people have plated a proximal humeral fracture with the head outside the joint. So, and I think that's a devastating situation. So, in my opinion, not to do a second view is almost negligent. That is what we practice here. You have to do an AP and another view. Most of the times, if you do a well view or what we call a strip view, it is much easier than a lateral view. It just requires the patient to go back like this, and you can get some sort of lateral view. In my opinion, to miss a dislocation, even if you miss it 1 in 1,000, is completely negligent. That's why I would prefer everybody to have 2 views. If you have 2 views and then there are CTs, as Dr. Maheshwari said, I do CTs if I'm not so sure whether to operate or not operate, if there is a head split fracture, or whether I have to decide between hemi and a reverse. But for me, not doing a second view, you will not accept only 1 view anywhere else in the body.
Right.
Why only shoulders?
Okay, Shashank.
Can I just re-emphasize one Dr. Pandey's point? Just a minute.
Shashank, your timing was not correct. It's not 30 minutes per lecture because we have 6 lectures. It can't be more than 20 minutes. And this is already 40 minutes we are. So please, I think we have to take care of the timing also.
Okay, so we'll just hand it over to now Vivek. Vivek, can you put on your presentation, please, while he's putting it up? Just to re-emphasize, PGs might think that we are just talking about the same thing time and again, but again, what Dr. Pandey said, 2 views, and most of the patients which come to me already come with 2 views or even 3 views. The problem is they are AP and lateral of the shaft of the humerus, just different angles of the shaft, a little bit internal rotation, a little bit lateral view of the shaft. They are not AP and lateral of the proximal humerus. So what Dr. Pandey is saying, 2 views, is 2 orthogonal or perpendicular views of the proximal humerus, not 2 views of the shaft. Please, over to you, Vivek.
Thank you, Shashank sir. Thank you, Maheshwari sir, Lalit, Maini sir, for inviting me on this DOA platform under the aegis of IOA. It's really an honor. So other day when Shashank told me, and I told him, I said, it's better that we divide all speakers and you only tell what everybody has to do. Otherwise, we'll be completely messing it up. So he asked me to discuss about where we take up actually the conservative treatment. Now that is a Pandora box, conservative, and especially when R.K. Pandey sir is around, a lot of things can be managed conservatively. So largely put, if you look at the proximal humerus classification, and since this forum is predominantly, engaging the postgraduates and maybe the general orthopedic surgeon, anything which is undisplaced or minimally displaced, that is the displacement among the various fragment is less than 5 mm, not much angulated, that is angulations are less than
Am I the only one not able to see his presentation?
No, I have not yet started. This is the first slide.
Oh, okay. Sorry.
Yeah. So let me give a brief and then I'll go straight to the case.
There is no slide, Vivek. It is all blank.
Yeah, it's a blank, sir. My mind is also blank.
Okay. So you're starting in a little
talking in front of the person who has been, our teacher, whose books we read. It's not easy to talk, but let me anyway, go ahead. So largely when the fragments, since this forum is again for postgraduates, largely when the fragments are undisplaced or minimally displaced with the displacement less than 5 mm, angulation less than so-called theoretically less than 45 degree, and especially if GT is reasonably underplaced, most of the fracture fragments are within the semblance, not moving around. Plus, what I always feel, what can be managed conservatively is The serial X-rays, which is done probably at 14 days and maybe one at about 3 weeks, that is 21 days, are not showing any major displacement. Then, according to Pandey sir also, that it starts becoming sticky, and that's the time you can mobilize. Because what looks undisplaced or minimally displaced on day 1 can actually displace by, let's say, 15 to 20 days. And you'll be surprised that when they come back at 6 weeks, it's completely gone haywire. The things which could have been easily fixed become unfixable. So my take to these, conservatively managed fractures is it should be minimally displaced or undisplaced, GT in reasonable position, and that is all very well theoretically described. Serial X-rays are extremely important. If I have to manage anything conservatively, I don't leave it and then call them at straight away at 4 weeks. I usually call them at about 14 days and then about 20.
Vivek, we are not seeing anything. Are you sure?
I'm coming. No, there's nothing, sir. I'm coming. Next slide will come straight. So with that, I actually told Shashank that I will take up a very interesting fracture, because rest is very, what do I show in all 2-part, 3-part fracture? Conservative, nothing else. So I thought I'll take up something which is often missed, and that is okay, so let me start from here. This is a 31-year-old woman, healthcare worker in my own hospital, who came to OPD with the history of fall from scooty 1 week back. And then somebody saw her. They gave her this is last year, June. They gave her, conservative treatment. She didn't respond in 2 days. Then they asked her to do the ultrasound. So she came to me with ultrasound. She had pain over the left shoulder and difficulty in elevation. And this is what is her problem. You see, it's difficult to elevate on left side, whereas right side, she was able to elevate. Can you see the video, Shashank?
Yes.
Okay. So passive movement was perfectly fine. And this is a very common scenario, what we see in trauma. Patient had a fall or the tip of the shoulder. These are relatively young patients who come to you with a so-called pseudo-paralytic litis like a situation. When I see such patients or my PGs they present, so I ask them what are the various clinical possibilities. Now the classic teaching is if the limb has to move, painlessly in the full range of motion, then you need to have a perfect bone, perfect joint, perfect tendon, and the neurological status. If we leave everything else okay. So these are the few things which should be all right. So one common possibilities here is fracture around shoulder. It could be in proximal humerus, since we are discussing it today. It could also be in scapula, because in the scapula patient will present like this. 2, it could be a traumatic cuff tear. And 3, it could be upper trunk brachial plexus palsy. Now, a point for all the postgraduates to remember, whenever somebody comes to me with a proximal humerus fracture and he has got some abrasions over probably the neck and the face. Now, this lady whom I'm showing these are all healed abrasions, but largely there could be fresh abrasion. Always and always and always rule out the upper trunk brachial plexus palsy. If you cannot rule out the brachial plexus palsy, at least write in the trauma sheet or somewhere in the progress notes that I have not assessed the neurological condition completely because of the pain or patient had difficulty in mobilizing. So don't think that if a person in the last here video, the one who's not able to lift, it's going to be only any fracture or a tendon tear. Okay. So from here we move on to the next part. How do we investigate? So clinical examination in this patient showed that he had some tender greater tuberosity. Her passive range of motion was fine. As you saw, active was decreased and there was no neurological deficit. Now, this is a question which is often sometimes, we have also discussed on our shoulder group, that how do you actually assess the neurological deficit in these patients? Nobody can miss a complete plexus palsy because they will also have the complete loss of movement even at the wrist and hand. So complete plexus palsy is very unlikely to be missed. Lower trunk palsies are not so common. Upper trunk can be missed because largely what happens, it's hard for you to see the movement at the shoulder. So what you should do, always check the dermatomal examination, C5, C6 definitely. If the patient can flex his elbow fantastically, because largely if you give them some confidence, they'll be able to flex the elbow, they will have roughly 4 plus power. Then likely that you have ruled out the upper trunk plexus palsy. If their elbow flexion is also very weak, then you have to keep it in suspended position that I need to come back probably tertiary survey after a few days. The other thing is you can always ask them to gently move. Now, boss always asks, Maheshwari says, how do you do this? So if you ask them just to do the gentle abduction, even in presence of fracture, remember, what you need to feel is the muscle contraction. You keep the hand over the deltoid, you can feel the contraction. So there are ways and means by which you should record, at least make all attempts of recording the neurological status of the limb before you proceed and jump onto some fracture. Because remember, NCV is not valid up to 3 weeks. So relying upon an NCV can actually overestimate the injury. Okay. So what are the possibilities? In this patient, since we had ruled out all the neurological issues, the possibility was supraspinatus tear and GT fracture. So how do we further investigate? You ask the patient to go ahead with X-ray. Now, this is lesser than, the classic beggar. Maheshwari sir, slightly less than the beggar. It's still in some amount of internal rotation, but it did not show any fracture. Okay. So the first question comes, and which often postgraduates think that there is not a GT fracture. That is not true. I'll show you something. Now, this lady in between, actually, when somebody saw, they said, okay, you might be having a rotator cuff tear. Now, remember, traumatic rotator cuff tear can happen. They do happen, but they are very unlikely, less than 40. Very uncommon. They can happen. So she was just 31. So I doubted that this is not a rotator cuff tear. They said it's a calcific tendinitis. All the more, who will have a calcific tendinitis?
If I may interrupt you.
Yes, sir.
You have 15 minutes to talk about conservative treatment of fracture humerus.
No, we have discussed with Shashank, so I'm keeping only the GT fracture.
No, not GT. Okay, let's concentrate on only the conservative management of GT fracture.
Yes, I'm coming only the conservative management. Okay.
Yes.
So then we asked for an MRI, and the MRI showed, look at this. So this is, sir, GT is also a part of proximal humerus. So I thought, because I discussed with Shashank, I said, what do I say? Because conservative is conservative. They are undisplaced. So let me take up something more specific. So in such cases, when you have a normal looking X-ray and patient has got a, still difficulty in elevation and so-called ultrasound looks normal, go ahead with MRI, not a CT, because often what happens in such situation, even CT can be normal, because these are kind of a impaction fractures of the GT. So these patients, you can always manage them conservatively because their diagnosis is undisplaced GT fracture. So whether it is a undisplaced GT fracture, undisplaced LT fracture, undisplaced neck fracture, the management protocol remains the same. It doesn't change as much. So you just give them a sling for about 3 weeks time. Older patient, maybe slightly early we can mobilize, but largely 3 weeks is fine. And then you can gently initiate the passive range of motion, followed by active assisted and followed by the active movement. But whenever you see a fracture line on an X-ray and you're planning to manage conservatively, the key is serial X-rays, something like what we teach in the lateral condyle of the humerus. Don't leave them. Sometimes what looks relatively lesser displaced will displace in due course. And that rule holds true for even other fractures of the proximal humerus. So this lady at about 9 weeks, you can see this is how she was. She had almost now regained, this is almost a year anyway. She was just at 9 weeks. She had regained almost complete active range of motion. Okay. Moving on to the second case. A 19-year-old engineering student came to OPD with a history of fall from bike. He had the same pain over the left shoulder, difficulty in elevation. When we investigated, got his X-ray done, you see here a small fracture, very small fracture here. In the last case, you did not see anything. Probably that was an impaction fracture. This is a minimally displaced tuberosity avulsion. And here, as everybody was emphasizing, in the last case, I did not show you because there was nothing I could see. In almost all cases, we also get another X-ray. I have never been very comfortable with this Y view. So either I try to get an axillary view. If I'm not very comfortable, I'll go ahead with the CT scan. If I'm in doubt, I'll go ahead with the CT scan. This was not much painful. So we asked for the axillary view. Okay, there's some mic which is open. Okay.
Please mute your mics, all of you, except Dr. Maheshwari, me and Vivek.
So here you can see there is a small fracture at the GT, but in the axillary view, you don't see that displacement. Now, why it is important to figure out this? Because the GT has got attachment of supraspinatus, infraspinatus, and teres minor. Supra will so-called pull the fragment medially, whereas infra and teres will pull it medially as well as sometimes posteriorly also, postero-inferiorly also. Okay, so I don't see, this is the glenoid here, you can see, this is the clavicle coming here, and I don't see any kind of fracture fragment moving more posteriorly. So we decided that it looks relatively undisplaced, and as Maheshwari sir was telling, as long as you can see the fragment reasonably undisplaced in both the orthogonal view, you don't need a CT always. So CT is a fantastic investigation, but use it judiciously. It's not some kind of a thing which you want to throw. It's like a spanner in every case you want to do it. So do we need a CT and MRI in such cases? No, absolutely not. Because here in both the views, it looks, in one view, it is slightly displaced, and other view, it is not at all displaced. So here also, we think this is a minimally displaced GT fracture, less than the 5 mm, so-called definition of the needs classification, because GT is also considered to be part of this proximal humerus fracture, and the management would remain conservative. But in such cases, as I don't know, let's see at the end of discussion, I usually try to do 2 X-rays, one at about 14 days and one at about 22 to 23 days. The time when I want to start their, mobilization, I want to see, is it the same at all 3 intervals? If it's acceptable, becoming sticky, then we leave it and we go ahead. So this was at the end of the 3 weeks. You can see it is still in the place, slightly has started uniting. So we went ahead with the conservative management, both the views again, AP and axillary. The third case here is a 43-year-old fisherman who came to OPD with a history of fall from bike 5 weeks back. He had pain over the left shoulder and difficulty in elevation. This was his first X-ray. This was done on day 1 in some other clinic, not with us. So you can see here in this view, it is within the so-called definition of needs. It's a large vertically split GT fracture. The first case which I showed you was a so-called impaction fracture. Second case which I showed you was a minimally displaced GT avulsion. This is the vertically split fracture. He was given a sling and asked him to go back and come back at around 3 to 4 weeks. He went there, and then that X-ray, I'm sorry, I don't have, but when he came to us at around 5 weeks, he had again weakness. He was not stiff, he was terribly in weakness. I don't have the clinical video, I'm sorry, I didn't take it. But then here we may need a probably CT, and this was the X-ray. You can see here, if I compare with the first one, which is here, now the fragment has moved more medially and probably it has started getting tilted. Though these 2 X-rays are absolutely not same, but it has started moving.
Vivek?
Yes?
So in this X-ray, I would not go for CT. Why would you think you might need a CT in this case?
No, because I'm not very sure with this kind of Shashank, the overlap. Here you see, though these 2 X-rays, if you see, this is the so-called true AP, which Maheshwari sir was telling. Okay, this is not the real true AP. So I'm not very sure whether this displacement, if I take the CT scan, if I find, okay, the displacements are still within acceptable limit, I don't need to intervene, then I would not intervene, because my decision making is a bit tricky on this one particular AP. In axillary view, if you see, it is not much displaced. Do you agree?
I think it is significantly displaced for a young fisherman above the AP view.
Absolutely. So I felt yes. I thought, okay, let me, and I have given him the form. Actually, he came just last week.
Okay.
So since my talk is only about the conservative treatment, so I will just leave it here and say that GT fractures, since my discussion with you was, I'll keep it limited only to this, are quite common after the fall in RTA, and it can be missed. And my take for all the postgraduates especially, including the young orthopedic surgeons, that beware of upper trunk brachial plexus palsy. I have seen many of them being missed. It has happened in my hands once. Undisplaced or minimally displaced fracture, whether they are GT or any other part of the proximal humerus, it can be managed conservatively. I personally feel that serial X-rays are important, especially in the vertical large ones, or even in the other 2 or 3 part of surgical and the proximal humerus fracture. Whenever you have a doubt regarding the displacement, like the last one I showed you, CT is must. Take a decision. Don't keep the decision pending because patient can't pay. I mean, those things are different, but as long as you are undergoing training process, in training, you must know what is right. large and displaced fractures should be fixed with the help of anchor and screw and plate. Just 2 points to show you here. This is how these, these tuberosities have got various attachment. And in fact, this is what they do even in a proximal humerus fracture. Why proximal humerus fracture displaces? Because of the attachment of various muscles around. Deltoid here, pec major here. Then you got the, the subscap here. Then you got the supraspinatus, infraspinatus, syntagmus minor attached onto the greater tuberosity. You've got various pulling forces. So as long as it is cohesive, not moved around, you can still manage it conservatively. These are the 3 different types of GT fracture. Not every GT fracture is same. Sometimes it is just the one, just a little split on top. This is the.
I think can we just skip it, Vivek?
No, this is it. There's nothing much here.
Okay.
These are the last, I think, one slide. And 30% are associated with dislocation, and almost 1/3 can have some kind of a neurological injury. Don't miss them. Thank you so much.
Thank you, Vivek. In a way, Vivek kind of brought out a different aspect of proximal humerus fracture, which is normally not discussed, which is GT fracture. Though I was expecting him to talk about conservative management of classical, 3-part, 2-part, 4-part fractures. But that's
मैं operate कर देता हूँ ना, मेरे पास X-ray का मैं I should have borrowed with RK Pandey sir.
That is what was expected, but I
okay. So to summarize Vivek's talk, and actually maybe RK Pandey might also talk about it a little bit in his PC pinning talk. Is the most important thing, the point for PGs is, if you are venturing out into a conservative management, don't ever just send them away. Take serial X-rays. Whether it is a GT fracture, it is a surgical neck fracture, if you're whatever you are treating, make them come to you every week, 10 days, take serial X-rays. And if any time, and that's where that beggar position comes handy, always take the X-rays in the same position. Always in the same position, neutral position, AP view, always same position. And if you ever think the picture is changing, because the picture can look different if you take the X-rays in different angles or in different types of AP views. So if you ever think that the fracture is moving, either the angulation or the GT is moving up, you have to tell the patient that you might have to go in. So that is the most important point. I would have liked Vivek to tell you where all he can venture into. And in short, I can tell you, if in AP and lateral view, if you see the head in front of the glenoid in a true AP view, if you can see the head in front of the glenoid in true AP and a lateral view, and GT below the highest point of the head in the AP view, if you can clearly see the GT below the highest point of the humeral head in the AP view, so 2 things: head in front of the glenoid in both views, GT below the highest point of the head in the AP view, and not significant angulation between the head and shaft, either in AP or lateral view. I think these fractures generally can be treated conservatively. If any of these criteria are not met, they might need surgery, though Proffer trial says that whenever in doubt, as before we started, Kapil was commenting, and maybe Dr. Pandey would elucidate more on it. If virtually all the proximal humerus fractures, except maybe head split and dislocated head of the humerus fractures, virtually all the proximal humerus fractures in proper age group can be treated conservatively if these 3 criteria are met. Dr. Maheshwari, do you have to add anything?
Yeah, so I think 2 points I want to add is about 3-part and 4-part. Often number of fractures are confused with number of parts. Whereas in needs classification, it is clearly declared that there has to be a displacement of 1 centimeter, angulation of 45. So just multiple fracture lines don't make it 4-part or 3-part fracture. They are, I can call them 1-part fracture. Even if there are 10 fracture lines, but they're not displaced in proximal humerus, it can be a undisplaced or 1-part fracture. That's one common mistake made. Now, second is differentiate between a surgical neck fracture and just below the surgical neck fracture. It is something like intertrochanteric fracture and a subtrochanteric fracture. The surgical neck fracture is quite stable. It may not displace, but as soon as this fracture goes in the metaphyseal part of the bone, particularly if there is a comminution, even an undisplaced fracture can cheat you tomorrow. It can displace. So the differentiation between surgical neck and just below the surgical neck is very important. Even if the fracture is undisplaced on day one, these are the fractures which will displace very often. I think these are the points I would like to make.
You have any distincts or any definition for this just below that? I mean, how much centimeter? Because PG should not go back with some kind of a new theory.
You know the surgical neck?
Yeah,
surgical neck, as soon as the head is round and it joins the shaft, that is the surgical neck of humerus. Anything below the surgical neck is in the cortical part of the humerus. That's not a cancellous part. That's not an impacted fracture. It's a waiting to displace fracture because it is coming in the cortical part. And also, if the fracture is surgical neck, but there is a comminution going down in the cortical part, that fracture behaves differently than a proximal humerus fracture, which is like conservative because it's all in the cancellous area. It will heal up more often than not displace more often than not, be impacted more often than not. That's not the same case with a you can say just below the surgical neck means maybe 1 centimeter, 2 centimeter below the surgical neck. So often these two fractures are put in the same basket, but they behave differently.
Dr. Pandey, can you get your presentation ready? You are muted. Can you unmute yourself? Is there any other comment from the faculty?
Another point I would like to make is clinical examination. If a fracture looks undisplaced, that doesn't mean it is not going to displace. If you see a lot of ecchymosis and open the clothes of the patient, you find huge ecchymosis. On the X-ray, it looks undisplaced fracture. Beware. It is a fracture with a high velocity, a lot of soft tissue, and tomorrow this fracture can displace. So clinical examination is very important before you declare that this is really undisplaced. A lot of these undisplaced fractures, so-called displaced in due course, because on day one, they were looking very, very novice, but they were actually not novice because there was a lot of hematoma around the arm. So I think that is a very important clue, which gives me an idea that to start with, this is a not nasty fracture. It looks novice, it's not novice.
I think it goes back to the same point, what I emphasize very clearly, that if you are planning to manage a patient conservatively, do serial X-rays. Yeah. Don't leave them and see them at around 3 or 4 weeks, when you start, because by that time you would have lost the bus.
So one small question, can I ask please?
Yes,
can I just make
Dr.
a comment?
Pandey, Dr. Vivek, and the moderators. So one question that comes is, of course, conservative. You've shown it very well, Dr. Vivek. But what if it's a little displaced, more than 5, maybe 7, or maybe 10, isolated GT fracture? So how would you like to really fix it? I mean, in a young person, do you go percutaneous, just screw fixation, or do you do a little better?
I think that is beyond the domain of his talk.
GT की बात हो रही है तो खत्म कर लेते हैं.
Chalo.
Just one small. Would you do a percutaneous thing, or would you like to do a little more better fixation with suture anchors or transosseous fixation?
I think R.K. Pandey sir will talk about it, but in general, Samir sir, if it is the large one, the type 3, the vertical split one, then I don't believe in this percutaneous. I usually open with a deltoid split and I put 2-3 screws, and sometimes there is an extension, and that's where the CT role comes, because often you may miss a small fracture going to the surgical neck. You actually saw only the vertical split, but there was a surgical neck also, so we always do CT. Whereas if it is a small split, which you saw the avulsion of the GT, the type 2 so-called, there we usually use the anchors.
Can I just ask the moderators or say anybody, how will they treat this fracture which is on the screen right now in a 59-year-old gentleman?
Okay, should I go ahead?
I told you the Pandey sir will bring, the traps. And he will discuss enough conservative.
Okay, I would definitely have gone and fixed this GT.
May I just interrupt? Sorry. There were some questions in chat box. I think we can cover up those questions. And that was about when do you mobilize a undisplaced or say conservative treatment fractures. And the overriding opinion is that you go approximately 3 weeks is the good time to start mobilizing. And if the patient is comfortable, you can go further. So 3 weeks, mostly no mobilization. But after 3 weeks, you can gently mobilize and still take X-rays every 2 weeks, maybe till 6 weeks. And callus you will not see. Callus is not visible in these.
Callus is not seen.
We will go mostly by clinical judgment. So I just thought I'll cover up those questions which were put up on the chat box.
Yeah.
So Dr. Pandey, what is the age of this patient?
59. Very fit and active gentleman.
Yeah, I would fix it in a 59 active. But let's go with your talk. Yeah.
Sir, since you've asked me, since you've asked, I think we would prefer a CT scan to be more sure about the displacements and everything.
Why do you need a CT
There is a good APN lateral view,
sure
Samir.
about, agreed, Shashank, but I would like to see the head more properly. I might be missing something. I mean, this is...
I did not do a CT scan, and this is after 6 months.
Yeah. So, okay.
The fracture has healed.
Yeah.
Obviously, just because it's non-operative doesn't mean you just send them away. He was x-rayed at week 1, week 2. I mobilize my patient as pain allows, pendular exercises, passive, gentle assisted passive exercises by 2, little active by 3. And then you carry on. But x-rays are taken first 2 weeks. The same patient at 1 year.
Nice.
I can't see your fixation giving him a better result than my non-operative management.
So Pandey, there are two very important things on the first X-ray you put up. Can we just look at the X-ray once more, please?
Yeah.
Yeah, one thing is, see that GT, if you look at the plane of the GT, it is still, flat, it's parallel to the ground. So that's one point. Second point is, there is a nice, like a little...
Can you elaborate on that, Nandan? Plane parallel to the ground.
So this is
not gone
the 2 points I want to maintain.
It's not gone posteriorly.
It's gone posteriorly, but if you look at the top of the GT, that flat surface of GT where the rotator cuff is attached, if that is parallel to the floor, many a times they do well with non-operative treatment. And that's one of the factors I am recently looking at and finding that is a very good parameter to see.
So
because
basically
if that
you're
tilts,
talking about the footprint area of the cuff. That should be parallel to the ground.
That tilts, that tilts, that means the cuff is off. That means it's not going to control the head. And that means the function is not going to be good. And that is something I'm observing recently. Another point I wanted to make about Vivek's thing was that mechanism of injury is very, very important in GT fractures. If you see that there is a graze on the acromial tip, then there is a likely compression fracture and that might not require surgery. Just as a ballpark idea. But if it is a traction injury, if it is a pull injury, then you're going to have a traction on the GT and that might require fixation.
Yeah,
most of them are torque or the fall on the like compression fractures.
Shashank, can I just interrupt?
Yeah. Not always.
Maheshwari sir, before you say something, can I say something?
No, let me say first.
What I wanted to say is the decision of conservative management is more difficult than operative.
Pandey, wait a minute. Pandey, I have not given you permission. So what I want to say is, this is a big problem with a panel discussion when there are experts. We start talking things which are rarely above the normal level, and the guys sitting there in the audience who are general orthopedic surgeons, who are postgraduates, are lost. We guys are enjoying. I know we are enjoying. I'm enjoying. But please, when you are discussing, keep in mind that don't talk about rare occasions, rare things, anecdotal things. You are in a PG class, more or less, or a general orthopedic class. Let's limit our discussion to something very clear points we want to drive home in every lecture.
The point taken, but the mechanism of injury is something which is always missed.
Yeah.
Right.
Before I start my talk, because we are doing non-operative measures, it's very important that the PGs understand that most proximal humeral fractures are treated non-operatively. Most of them. And there is a PROFA trial, which is very good trial, which all the PGs should also know, that if you see an X-ray of the proximal humerus and you are not sure whether to operate or not to operate, if you look at the X-ray and thinking, oh, I don't know if it's too displaced or not displaced, if you are in two minds, better not operate, because the results are going to be as good as with surgery. So that's my my bit for the day done. But can I start my talk now?
Yes, please, go ahead.
So I'll talk about percutaneous or minimally invasive technique for these fractures. As I tell everybody, this is not just a bony injury. It's a soft tissue injury too. And just because you get a good X-ray doesn't mean the patient will have a good function. So you can put a lot of metal work and put everything where it belongs, and it all looks nice on X-ray. Patient may not have any movement. So it is to be considered a soft tissue injury as much as a bony injury. So there is no consensus, as you have seen in the discussion. There is no consensus amongst shoulder surgeons to know the best way to treat these injuries. The challenge is to match the right patient to the right management, and then to the right implant and the right surgeon. Remember, the right surgeon is extremely important in treating proximal humeral fractures. You can cause enormous harm if you are not very well versed with various implants and various techniques to treat this proximal humeral fracture. And your Hippocratic oath was do no harm. And that's crucial in proximal humeral fracture. You will see plenty of x-rays, which I will show a bit in my next slide, that if the right surgeon doesn't do the right implant or the right treatment for the right patient, you end up in trouble. And if there's one message I can give today, it's that. Don't just try to treat just because you have a patient. You give it to the most appropriate surgeon for that fracture. And displaced fractures, four-part fractures are very difficult, especially in young patients. In old patients, four-part displaced fracture is a lot easier because you do an arthroplasty, which Kapil will talk about. But in young patients, four-part fracture is an extremely difficult fracture, which cannot always be solved by just a locking plate. So here are my top tips, and this is just reinforcing the point for the PGs. Always examine the patient for neurovascular injury, axillary nerve, brachial plexus, crucial, as my colleague, Dr. Vivek Pandey has said. We are very good in examining bones. We are very poor in examining nerves. A lot of these patients have nerve injury. I always say, always have two views. We will not accept one view in anywhere else. Why would you accept one view in shoulder? Always have two views, because many times CTs are not easily available. And the third point, which I have put here, and this is, in my opinion, is most important. Never miss dislocations. And it is absolutely crucial, because if you miss dislocation, that's catastrophic. The biggest problem we still have is we miss many post-traumatic dislocations because we are not suspicious of a dislocation. I would never leave a patient till I'm sure his head is in the joint. If you're unsure, you do further imaging, more x-rays, more CT, but we still miss many dislocations, and which is unpardonable in my opinion. I want you to see these x-rays and just think for a minute. These are all done by various surgeons, plates, nails, and you will agree these are all disasters. And I tell you, I'm sure all the senior guys here, Dr. Maheshwari, Dr. Pandey, Misra, and Raman, Kant have all seen disasters like this in their clinic. And this is all because the right patient hasn't received the right implant by the right surgeon. So just because you have an implant doesn't mean you'll get good results. The problem with big incision, a lot of metal work, is you have high rates of complication. Extensive soft tissue dissection can lead to avascular necrosis and post-operative stiffness. And the biggest problem is if your metalwork fails, it's devastating. Salvage is difficult. Most of the time you'll have to do an arthroplasty. An arthroplasty after a failed fixation doesn't give you very good result. So let's take some cases here. Now this is a 52-year-old male after a fall, has pain and limited range of movement in this shoulder. So Shashank, what is lacking in this?
One is a lateral. So one, it's not a good AP view according to me. Absolutely. And a lateral view. Yeah.
I will not comment. If someone showed me that X-ray, I will say, no. I want a lateral, axillary strip or a Valpy view, but another view. This one was missed. This X-ray was taken. They thought, this looks like a simple fracture. Put them in a sling, send home. Look at this. The same X-ray, axillary view shows this is a posteriorly dislocated shoulder. And a CT scan shows it's not just not a dislocation, it's multiple fragments. It's broken here and it's got multiple small fragments. So this what looked like a simple fracture is a very complex fracture in a relatively young patient. Now now we can think how we treat this. The first principle is this needs to be reduced, and then you may want to fix the fracture a bit because you want some sort of mobility. You can put a plate, you can put all sorts of other things. How I treat it, I try and make as little, as small an incision as possible. So in this one, I made a very small incision in the front and just put a small pennybacker, pushed the head from behind and relocated the joint first. And once the joint has been relocated, you can put a big plate if you want, but that will require a big cut, a lot of screws and plates. But here I've just put few screws. I've fixed the tuberosity and got the shaft to the head, and it looks pretty good. I don't want to do a lot of I don't want to put a lot of metal and cause a lot more stiffness here. And this is the patient after 6 months. The fracture has completely healed. It looks almost anatomical. I don't need to make it anatomical. If I can put the tuberosity in a reasonable position, the head in a reasonable position, and the fracture heals in that way, you will get a very good result. You can make the X-ray look much better by putting a lot more metal work, but you will not get the desired results. Now, I do this quite regularly. The same patient, you can't even tell which shoulder is injured. And that is because I respected the soft tissue here. It's not just a bony injury, it is a soft tissue injury. Do not cause more soft tissue injury by your surgery. This is another very complex fracture. Yes, you can. This is a youngish patient. Yes, you can go and put a plate and put everything down. So what I do is I lift the head, reduce the head, put the tuberosity down, and just put percutaneous wires and then substitute with screws. And you can get fairly good. It's not perfect reduction, but it's pretty good. If it heals in this position, you will get as good a result as any other fixation. I am not saying that this should be used in every fracture. If you are going to be a person who does proximal humeral fracture, you should know all techniques available. There is no one technique for all the fractures. So you need to know plating, you need to know nailing, you need to know percutaneous, and you need to know when to do conservative management, and you also should be aware of arthroplasties. But this is another 62-year-old. Again, this fracture was initially missed because they have some sort of X-ray here and a lateral, not an axillary. But if you look very carefully, the head is here, which can be easily missed. So if you look closely at the proper X-ray, you see the head is outside. Now, this is a fairly young, active lady, and I thought, well, I should use my technique and try and put this back and fix it minimally. So I made a small cut in the front, reduce the head, fix it with wires first, and then substitute it with screws. So everything looks very good. But I know that this head is very, very vulnerable. But I was very happy. At 6 months, it is almost healing. The screws are backing out. And this is the advantage of minimally invasive technique is if the screw backs out, it doesn't go into the joint. It backs out that way. So after a year and a half, it backed out a bit more, and the lady was complaining of pain. And I thought the screws are backing out because she's complaining of pain. So this is almost a year and a half, and this is 2 years. I removed the screws under local anesthetic. She's still complaining of pain. This is 2 years after the injury. And 6 months later, I took the same shoulder X-ray again, and you can see the head has gone into avascular necrosis. So this is my other point. You may fix the fracture very well, but humeral head can go into avascular necrosis, especially if it's dislocated or if it's a very sort of anatomical neck fracture. And humeral head takes a long time to show that it's going into avascular necrosis. I was very, very happy, and I used to show this X-ray to various places in various conferences. Let's see, my percutaneous spinning is doing so well, but this one it didn't. But this, I don't think this was because of my surgery. This fracture was destined to avascular necrosis, whatever I had done. So eventually I had to do a reverse shoulder arthroplasty because her cup was also not great. So I've shown you two success stories and one failure. And I'm also trying to tell you that choosing your fracture for the right implant is absolutely crucial. Choose the right patient. A young patient who's 25 is very different to somebody who's 75. If you are going to sorry,
Dr. Pandey, may I interrupt you for a moment? Because we're just talking about the right patient. The failure you showed just now actually is not the failure of PC, as you very correctly pointed out. So where would you not do a PCY, percutaneous screws? Where if you wouldn't have chosen to do a percutaneous, you would have,
If it's a very displaced fracture, like the head is very displaced and the shaft is very displaced, tuberosity. So if they are not connected to each other, I will not do a percutaneous because it's very difficult to reduce things. But if they are just angulated or displacing, and I can just put some sort of instrument to push things back into roughly the same place, I will do a percutaneous fixation. Things which are not hugely displaced.
So what I gather from you is the fragments are far away or they are not in contact with each other, you will not do a percutaneous spinning.
No,
and if they are in contact,
I will avoid that because reduction may become very difficult.
But dislocation of the head is not a contraindication for you.
No, not in my books. If you can reduce it without causing a lot of soft tissue damage, once the dislocation is reduced, you'll be surprised everything falls back into its original place most of the time. And then all you need is simple fixation.
And do you look for cortical comminution before you decide? Is that a contraindication? Medial cortical comminution?
So if it's a varus, the head has gone into significant varus, then percutaneous fixation is not the best option because then you need something more solid. Sometimes you have to put a strut bone inside the canal to support it medially. So if there is a lot of medial comminution and the head is actually in varus, then you may want to avoid this kind of, because it will fall back into varus. But if you're putting just a plate for that kind of fracture, also you'll have a problem.
I agree with you. I'm sorry to interrupt. Please carry on.
Dr. Pandey, if I just carry on the discussion based on the chat box there, we have been fed in our mind that articular fractures have to be fixed well, they have to be mobilized early, otherwise you'll end up with stiffness, blah, blah, blah. What happens here? You have fixed everything, but your fixation is plus minus, though reduction is okay. I'm sure you're going to immobilize them for a long enough time. Is there a kind of a side effect of doing a delayed mobilization? That is another question Dr. Smarth Mittal has asked. When do you start mobilizing these fractures, which you fix with this kind of a minimal implant fixation?
So they start pendular exercises as soon as they can.
That means 2 weeks.
2-3 days, they can start pendular exercises. I keep them in a sling for about 2 to 3, mostly 3 weeks. But at 2 weeks, they can start doing assisted active. So they are not immobilized for 6 weeks. They are immobilized maximum 3 weeks. And they can start mobilizing. So there are many categories of mobilization. They may not be doing active mobilization, but they can do assisted active by 2 weeks' time.
Right. So you're not very particular about early mobilization as has been fed by the AO group.
So nobody knows what early mobilization is. My patients have a bit of pain, so they don't do a lot for the first 48, 72 hours. And when people do hemiarthroplasties, they keep the patients in their sling for 4 to 5 weeks sometimes. Rotator cuff tears, people keep them in sling for 5-6 weeks sometimes. So, but after trauma, if you mobilize them within 3 weeks, you will be okay. I don't think you need to rush and fix it. And this is not an easy technique. Percutaneous technique is very, very difficult because you have to know the 3D anatomy under the X-ray, 3D anatomy of the shoulder and an X-ray. So patience is important. Thank you.
So just for the knowledge of the audience, I've asked this question on the chat box of the faculty. How many will do it? And two of my senior faculty have actually shown their kind of, you can say reluctance, or they're not comfortable because it's a very demanding technique. So I'm sure there is an indication Dr. Pandey is an expert, but this is something one has to think of, particularly in our situation where a lot of time there are all kind of constraints. And if you learn some so-called difficult techniques to bail you out, I think it is worth giving a trial on learning those techniques. Anybody else wants to come in and make some comments? Anybody amongst us?
I think there is no other question. Somebody has commented. I think, can we go to the next one? So while I invite Raman for his cases on plating, Raman, can you share your screen? I would just re-emphasize something what Dr. Pandey said in the last slide, right in the end. Some of you just might have missed it. Imagining the reduction in a 3D way in 2 X-rays peroperatively. That is very important. And many of the catastrophes after the fixation are done because in the chaos of OR, we don't take a good lateral view while we are finishing. Either it is the surgery has gone on for too long, or we haven't seen preoperatively whether we can take a good lateral view on the operating table. There are many reasons, but if you go back, and I'm talking to PGs, I'm not talking to faculty here. If you go back to last 5 or 10 cases you might have done or assisted, go and look back carefully how many times was that fixation or reduction peroperatively was actually assessed in a good lateral view. That is something Dr. Pandey mentioned right in the end, and I hope everybody has noticed it. Please get 2 views before you start your surgery, before you paint and drape, to make sure that you can get a good lateral view on the table. And then once your reduction, once your wires are in, before you start doing your final permanent fixation, make sure that the head is and the GT is reduced in both AP and lateral views, and then right in the end. With that, let's give it over to Raman for his talk on plating.
So everybody can see my screen?
Yes, please, go ahead.
First of all, I would want to issue a caveat. What Dr. Pandey does is akin to the stunts being performed by the motorcyclists. This is a message for the PGs. Believe me, don't attempt it at home. Don't do that unless you are an expert. And he emphasized again after Samir that fracture is a soft tissue injury. Absolutely true in proximal humerus. And think of the muscles and think of the blood supply. And it's just a slide for the PGs. This is what I do and how do I decide what to do. I use Neil's classification in my AP view. I use rest classification for my scapular lateral Y view. And this tells me whether I have to operate or not. I also use Robinson's valgus fracture classification for my valgus fractures. I use Shibbol's classification for head splitting fractures, and I apply Hurtel's criteria. I presented this case. Now, this is a case which I did around 11 years ago. This was a gentleman, 28 years, right-handed submarine engineer, and he had no neurovascular injury, but the shoulder was so tense, and I dared not go into the shoulder, looked like a hip. This was what he had got at that point of time. Now, I did not do the CT in this case, and I'll tell you my reasons for not doing the CT. I could see the lesser tuberosity with the shield fragment on, with the bicipital groove onto this fragment. I could see the GT, which was comminuted. I could see the head with Hurtel's criteria, maybe 8 millimeter, maybe not. I was not sure, but it was totally out of the socket. And of course, I can see the shaft. And I knew that what are the choices? Conservative, I don't think it's going to succeed. I'm not as good as Dr. Pandey. Hemiarthroplasty will be stupidity at 28. So I had no option but to do an open reduction and internal fixation. Well, I am not, I am not very good with nailing. And I don't know how many of the faculty in this particular scenario will choose a nail, which we can come into the discussion, but I chose a plate. I chose a bone graft, which was structural. And I took tricortical iliac crest so that I could also take some cancellous chips. So this is what it is. I tagged both the pieces of the greater tuberosity. So there were 3 sutures in the greater tuberosity. There were 2 sutures in the one suture in the subscapularis in the lesser tuberosity. That was the iliac crest graft, and that was the shaft. And I closed it like a book. And this is a very important part. Patients who have extreme pain, I usually put them into the neutral wedge brace, which gives them a 30 degrees external rotation, and an ER brace or a neutral wedge brace. You can rotate the belt and a patient can achieve some kind of external rotation as well.
Raman, can I interrupt you just for a moment?
Yeah.
What was the logic behind putting that iliac crest? You didn't put chips. You put just a block of bone there, is it?
No, I put a tricortical structural graft of the iliac crest.
So there was a loss of bone tissue there?
Let's go there. So this is the shaft.
Yeah.
The calcar of the shaft is broken. Okay. This is head. Head has lost its spherical shape. It's just not even a hemisphere completely. You can see the medial calcar there, but there's a lot of combination there. So a lot of void.
Okay.
This was the X-ray at 12 weeks. I could see my screw. The head has started collapsing. I could see this screw also pulling out, but I insisted with my rehab. I had to take the plate out at 9 months because there was some kind of inflammation at the distal end of the surgical scar. So I took the plate out. This is what the X-rays looked at 9 months. This was at 2 years. And I know the head has collapsed now. This is just 3 days ago. Patient is 39 now. And what kind of function do we expect out of this patient now? See the axillary view, there is no head and sclerotic. This is the function, and patient has lived with 10 years and he doesn't give a damn if he has to do some heavy work. Surgical scar rather misplaced, which was more pectoral than deltopectoral. That was the coracoid, and look at where the scar has gone.
Raman, was the head dislocated in this case initially?
Lateral dislocation.
Yeah.
Extreme end of the valgus spectrum injury, lateral dislocation, slightly posterior to the shaft. I did get a CT, but actually I could get all the information again in this case. There's no need to see what is the head like. Head is not even a hemisphere completely. I see the double arc there. That's the GT. I see the facets. I see the head, subchondral bone there. I see the lesser tuberosity there. But I got the CT done, which confirmed my findings. I see the humeral head there. I see the GT there, LT there, and we see the shaft and 2-3 wires there. So it's a 4-part fracture dislocation, which is laterally gone, extreme end of spectrum of valgus injury. So what are the options? Again, because of 44 years, I couldn't subject the patient to a hemiarthroplasty. So I opened up to fix with a graft. So this is the head. The articular surface is facing laterally. That's my subscap, and my lesser tuberosity. That's my greater tuberosity. And head was out because after 7 weeks, that was the head on the table. So I refixed the head onto the table after I put the fibular graft there, iliac crest graft, and then I fixed the head. It was very difficult to achieve whatever rotation. I just use it as a hemiarthroplasty head. That is what I got on the C-arm. That is what I got 3 months after the surgery. And the screws were nicely spanning out into the humeral head. This is an X-ray after 33 months. Basically, this month only I got these X-rays. Again, the head has collapsed now. But look at the function. It's the right shoulder. So my point is, do not fall into the trap of rushing in. If you see a very bad shoulder, the crux of the problem is the GT, as has been emphasized time and again. If you could bring the tuberosities to heal with the shaft, head can be replaced at any point of time. But it takes some time. It takes at least 9 months to 1 year for the head to collapse. So utilize this time in restoring the biomechanics of the shoulder by bringing the rotator cuff back to the shaft so that patient can lift. But if you go for a hemiarthroplasty, in such a case, the results are 50% on day one, even in the hands of the best shoulder surgeons. And even in those 50%, these results fall back to again 50% failure rate after 5 years. So the eventual survival of a 1 in 4 hemi will survive. So do not fall into the trap of going into a replacement, especially at an early age. I would like to present one more case. So, sorry, just a minute. Now, this is a lady, this was the fracture which came to me with a valgus kind of an injury. I could see that I cannot discern the greater tuberosity from the humeral head, and I see some subcontinental cyst as well. So probably rotator cuff disease was going on. This was the patient's lateral view. As I said, I do the lateral views more often. That was the lateral view. That was the lateral view after 4 weeks. There is callus forming there. And that was the AP view showing the callus at 4 weeks. But when the patient presented to me, the patient had rotator cuff tears and patient couldn't hold. So I insisted with the rehab. In 6 months' time, that is where the patient is. And she doesn't require, she saved a reverse shoulder for herself. So as Dr. Pandey said, very judicious use of whatever we do, cater to the patient's needs, expectations, is very paramount for the success of your intervention. Thank you.
Well, thank you, Dr. Raman. I think one carry-home message from the talk is, and I've seen this time and again, most orthopedic surgeons concentrate on 90% of their life in fixing the head to the shaft and getting it right, which is important. But they spend about 10-15% time in taking care of the tuberosities, and it is done rather casually. And I think the message that Dr. Raman has given is tuberosity healing in the right position is more important, if not as important. Even if the head collapses finally, you have seen all these funny looking x-rays, but the common thing was that the tuberosity has healed in a proper position. That's why despite a AV and despite of a funny looking shoulder joint, the functions were eventually good. So I think the message is, when you're fixing these fractures, make sure that the tuberosity is reduced properly to the shaft, and all attempt is made to fix it very well. It doesn't displace during the course of the treatment. I see so many cases where tuberosity was fixed on day one possibly, but it got detached because this was done in the last 5 minutes of the surgery, was fixing the tuberosity, taking some casual sutures through the tuberosity and fixing it through the holes. So I think tuberosity fixation and tuberosity healing is key to good results. That's what all these 3 cases have shown. Okay, so anyone else wants to come in with a comment?
Dr. Maheshwari, can I also say one thing? Another thing which is very important to know here is what we call get it right the first time. If you do the first surgery properly, it reduces patient morbidity so much. So as I keep saying, you have to match the right patient with the right surgeon. I think if Raman had got those two patients first time, the results would have been even better.
Well, that's a big philosophical issue, Dr. Pandey. It is easier said than done. Where is the best surgeon and the right surgeon and the right patient and the right implant? That's a big issue. Anyway.
Sir, with the collapsed head, I'm sure there must be pain. I mean, where's the cartilage? I mean, head is collapsed. There is no cartilage to cartilage. So it must be painful. I mean, how can a person have no pain at all?
So that is what I asked the patient, and if the patient is happy with whatever he is doing, and I asked him, he said, "Sir, मुझे ध्यान ही नहीं रहता कि मेरे shoulder में कोई कमी है, मैं अपने जो भारी काम भारी वजन में उठा लेता हूँ."
Samir, may I say the issue is different in lower limbs than upper limbs?
Yes. So we see this time and again. We say, Samir, it's a very important question that you raised. Avian of the humeral head is totally different from the avian of the femoral head, simply because it is not a weight-bearing joint.
Well, I don't fully agree with the statement, Dr. Misra, that it is not a weight-bearing joint. Shoulder is a weight-bearing joint.
Okay.
In internal rotation, shoulder bears 75% of the body weight. In external rotation, shoulder bears 50% of the body weight.
No, it is a relative thing. It is a relative.
It's relative. Yeah, but pain somehow, and Christian Gerber has also stated, and many people, that avian is tolerated rather very well. Yes. Because vis-a-vis the choice was hemiarthroplasty, and we would have screwed the patient straight away.
Yeah.
75% chance that patient would have failed to even lift the arm.
So the question Samir has raised is, how come you have a good result, painless shoulder, despite a bad-looking X-ray?
Yeah.
It's not something uncommon.
To be very frank, after seeing these beautiful X-rays, Dr. Raman, I must congratulate you. You really wonder, why is the head actually necessary? The spherical head, why is it necessary?
So this is what, because once I did it, and then I said, okay, I have to do a hemiarthroplasty. So I'm going to use the same humeral head, even if it is on the table, as hemiarthroplasty. But my attention is on the tuberosities. Head is going to go away, and I always take the plate out.
Well, I would like audience not to take wrong hints. Sometimes things go in your favor. That doesn't mean that that's the way you should treat. I'm sorry to say there are anecdotal surprises, and that's not the rule. But the bottom line is, if your tuberosity is healed very well, even if the head is not in a good shape, in shoulder, it forgives you. It's a reasonable good result.
Yeah, I think that's a good statement. With that, I think let's go to Nandan.
Yeah. Nandan.
Yeah, thank you very much, Shashank, for the opportunity. And this is a talk, as we discussed, is only about the technique of nailing. I'm not going to talk too much on the technique, but a few tips and the main indications for nailing of the proximal humerus. Interestingly, we were talking about how many of us actually do proximal humerus nailing. When I started my training in UK after finishing in India, I saw that in the unit I worked in Leicester, where Mr. Pandey is, and he's my mentor too, we have noticed that they were only using nails and there were no plates when we actually initially started fixing these fractures. Interestingly, the professor who was there used to use rest nails, and then we went on to using locking nails, and then we went on to using more advanced nailing techniques, which we'll talk about. And then we also used the proximal humerus plates at a much later date than most other people. So I grew up with the nailing system. So first we'll start off with cases. We see a 45-year-old gentleman with this type of X-ray, and there is this tendency that whenever you see a fracture, a proximal humerus fracture, you want to fix it. But if it is a undisplaced one like this, with the tuberosity in the right place, the glenohumeral joint is aligned, just go with non-operative treatment. Okay, so don't need to put any metal work into that. But if it is a varus fracture like these, you can always think about, plating, nailing, and percutaneous fixation. But Mr. Pandey had very clearly mentioned that varus ones don't do very well with percutaneous fixation. So you need some sort of good internal support to hold the head. Now, this situation could be used for nailing. But if you look at it very closely, there is a fracture going through the greater tuberosity. If your nailing system does not allow the tuberosity to be hold properly, then that will also fail, because that will not hold the tuberosities, but will hold only the head. Raman has elegantly described that Head is not as important as the tuberosities. So with the nailing, that is one setback we have, but the new system does allow tuberosity healing as well, which we'll touch upon later. So this particular patient, when I didn't have the recent implant, I went ahead and did a plating for this to restore the humeral anatomy. The most important point in any proximal humerus fracture, to that matter, any fracture, is reduction of the fracture. We blame the implant a lot of time, but it is not the implant, it is how you have reduced the fracture and how you have held it is what determines the function. So again, another example, 44-year-old lady, she had this particular fracture. One of the young surgeons went ahead. This is the corona time last year in March. She was wanting to come to me, but because of corona, she did not come. And then in March, she had this injury. The local surgeon fixed it. And obviously, we all go for Phelos plating because that is what we do for proximal humerus fracture. And that is what he did. So this is my message that if you not reduce the fracture, a reasonably looking bone, which was, could have been managed with even percutaneous pinning or a nail, has went on to this. And unfortunately, this is on a slippery slope. And this went on to having the screws penetrating. The head actually, if you look at it, is looking downwards. It's not even looking towards the glenoid. So this lady required a reverse shoulder replacement just 2 months ago. The key to success, as Mr. Pandey had mentioned, is a right implant, right fracture, right patient, and the right technique. So you should know your implants. It's not that any implant is the same. Use the right technique and most importantly, reduce the fracture. So this another example, 54-year-old gentleman, a 2-part fracture with a posterior inclination as well as a varus inclination, but it has a good head and a tuberosity fragment. So for the entry of your nail, it is an ideal case. So if you are a starter, please go for nailing in these sort of patients where you have a single head and GT fracture fragment and a separate humeral shaft. So initially, this is the best indication for a nailing. So this is what she had. And that's a newer nailing technique, which we'll talk about. So nailing is indicated mostly in 2-part fractures and in if there is a diaphyseal extension with a proximal humerus fracture, then you can use it. And pathological fracture is very useful because you can span the whole of the humerus with a long humeral nail and also get a good capture of the head. Nears 3 and 4 are relative indications because you should be able to capture the tuberosities more than just fixing the head onto the shaft. Now, curved nails were the initial ones because we always grow from a lower limb surgery onto upper limb surgery. So curved were used in femur. So we thought we could use the same in the humerus. So that's how we went on to curved nails. And Polaris nails initially were curved and now they have changed the design. And they have been used in 3 and 4-part fractures. These nails we had used in early 2000s in UK. And they had reasonably good results. Again, the important thing was that reduction was important, and these patients actually required more of implant removals. We'll talk about it later. Advantages of nailing, like with percutaneous pinning, there is less soft tissue damage, but there is a breach to one of the most important soft tissue in the shoulder, which is the rotator cuff. So meticulous attention to handling your rotator cuff during surgery is the most important part of your surgery. So types of implants, we went on to non-locking smooth nails, to curved nails, to straight nails. And now we are also talking about angular stable nails with the screws being locked into the nail itself. So this was what we used to use, and these failed miserably because we are not at all concentrating on the rotator cuff fixing onto the shaft. This gentleman, another example, 2-part fracture, good example for a proximal humerus nailing. So this is a T2 nail where in this particular nailing system, the screws actually lock into the nail itself. So there is a washer inside the nail and they lock in. This was a system which was developed in parallel to our locking plate system to hold most of the bone.
Nandan, can you go back to the X-ray?
Yeah.
So can you just, I see this nail is straight. This is not like the curved nail which goes through the GT.
Correct. Yeah, we'll talk about it slowly with next slides. So this is the screw onto the nail, and the screws are in different directions, will hold the head so that you'll have a good capture of the head fragment. But mind you, again, there is a problem with fixation of the tuberosities. All these systems had actually given us a outrigger, which will actually turn to the front, and we can put a screw from the lesser tuberosity down onto this part. But again, these never held well, and you could never locate the lesser tuberosity very well. So that was one of the drawbacks of these nailing systems. So ideally only for two-part fractures. If you look at the curved nail and straight nail, so these are all the newer straight nail systems where the whole nail is straight. Previously, we used to have nails which used to enter more on the lateral side, like so. And the problem with these is that they would enter exactly at where your rotator cuff footprint is. And that was the biggest drawback of these. And they would lead on to tuberosity fractures and other problems, and their results have been poor. And that's why nailing has had a bad repute in the proximal humerus fixation. So that is where the entry was, where we don't want it to be. Okay, so the straight nail definitely is better because it is technically demanding, but the entry of the nail is correct, and the entry of the nail is usually through the belly of the rotator cuff, not through the tendinous part of the rotator cuff. So the damage to the rotator cuff is lesser, and your entry is more on the humeral head with subchondral bone holding proximal part rather than the lateral aspect where the tuberosity is placed. And many a times with the straight nail, you get a valgus positioning of the head, and with a curved nail, you get a varus positioning, which is not ideal for proximal humerus fixation. So there was an randomized control trial comparing the two, and they found that the straight nail had less shoulder pain and less reoperation rate because the problem with the metalwork was lesser with the straightened nails. So straightened nails are better than a curved nail. So if you have to choose a proximal humerus nail, choose a nail which will lock the screws into the nail and is straighter, but your entry point is the most critical point. Okay, as long as the entry point is in the line of the shaft of the humerus, like so, you will have a good result. So to achieve that, you should have a good reduction. So always reduce the fragments first. Now, how you reduce the fragments are some tricks and tips I will give you later on. Technique wise, we give it is a supine or a B chair position. I started off B chair, now I'm doing it all supine, much more easier. Regional block can be done, and surgery can be done purely under regional block as well. It's a deltoid split incision. And most importantly, the structure at risk is the axillary nerve. So be careful not to extend beyond 5 centimeters of your incision. And one interesting thing I'll tell you about the newer straight nail, the AVO nail, is that the distal screws are actually very close to the radial nerve. And that was confirmed on one of the anatomical studies published about 4 years ago. So be careful when you're drilling the distal hole. Technique-wise, supraspinatus is split. I always place 2 sutures, one on each side of the rotator cuff, then incise in the center, so like so. So you can actually retract the cuff with the sutures and look at the humeral head. Once you have looked at the humeral head, then put in your pin. And the reduction is best done with the sutures. So you pull on the sutures, reduce the head, you get the head into neutral position, then only you start your entry point. Never ever start your entry point without reducing the fracture. So if it is difficult, you can use joysticks to maneuver the fracture into alignment and then pass your guide wire into the head and to the humeral shaft. But if you have a situation like this,
and
it's very easy. Yeah.
Nandan? Yeah. So can you please elaborate a little bit more? So your 2 sutures are one on GT and one on LT, or are they on the supraspinatus?
No.
The 2 sutures
on the supraspinatus. The supraspinatus is like that. So you make a cut.
Because you're going to the belly, not from the
tendon. You take one suture here and one suture here. So you're taking 2 sutures to retract the cuff on each side. And these 2 sutures, when you finish, you can actually tie up and you will close the cuff. Okay? So if you have a displaced fracture like this one, which I've shown this down there.
Sorry, yes. Carry on, please carry on.
Musculotendinous junction of the supraspinatus.
Okay.
So if you have a fracture like this, where there is a pull of the pectoralis major, which is pulling the shaft more medially, and the head is more lateral, then you can actually introduce a finger through your incision down to the shaft and give traction to the shaft and push the shaft down. And that's a very good way of not causing damage to neurovascular structures medially. Don't put any sharp instruments down there to pull your shaft, because you're going to pull the axillary artery in your hand. So that's the technique. This is what I was talking about. So we pass 2 sutures. I'm emphasizing on this very much because this is the most important step of the whole of the operation, so that you don't damage the cuff. And you can actually see a bit of the humeral head there. So these two sutures on each side, you're pulling the cuff on each side, the guide wires go in the center. And then you use your protective sleeve. Then you can proceed with the nailing. And the jig system, you can turn it to front and to the side.
And what is the position of the arm at this time? Is it around on the side of the trunk or adducted on the chest?
Yeah, it's in the side of the trunk. In this picture, you can see it's very clear. It's just on the side of the trunk. It is neutral. The other important thing you should always remember is the greater tuberosity is in line with the lateral condyle or lateral epicondyle of your humerus. So if you actually keep those two in line, your rough rotational alignment. Because many times with the humeral nailing, there is a tendency to keep the arm in internal rotation and fix it. So once you do that, the whole humerus head and the shaft angle changes in rotation. So that causes problem with the rotations later on.
Okay.
So this is the newer system we are talking about, where you have the holes in the screw. These screws are blunt tipped, so it won't pass through the articular surface. Even if it does, it will not damage the glenoid. The second thing is there are holes in the screws where you can pass sutures from your rotator cuff onto the screw. So you are actually holding the tuberosities down. So this system is amenable for using in a 3-part fracture, but provided you have a reasonable good chunk of the humeral head and you have reduced the head and the greater tuberosity before you put in your entry point. So that's the screw going in. So that's the technique point of view and some tips. But another example here we are going for is, I told you that we can use it in 2-part fracture. If anybody would like to do a nailing in this particular lady, Dr. Maheshwari or Dr. Shashank.
Yes, I would consider, because she's an arthritic patient and I would like to give her, and very osteoporotic. And I think if I turn the head properly, I'll get a reasonable space to go in with the nail. Considering osteoporosis, considering early mobilization required, I think nailing would be my choice in this case.
Okay.
I'm surprised.
So this is another point I was about.
Deepthi, can I ask you something?
Yes, Raman, please.
Deepthi, why would you operate this patient?
Exactly.
This, okay, fine. I'll show you another X-ray. Then you tell me.
Yeah, sure.
Now you tell me.
Still, if I see the AP view, the tuberosity, as you said, I mean, the head has gone into slight valgus, and the tuberosity is overlapping.
Varus. No, head is in varus.
Actually, here the CT opens the complete card. The tuberosity in this case, the head is in kind of varus. Actually, varus is getting exaggerated because of osteophyte.
The point you're all missing is this, that there is a big osteophyte on the inferior aspect of the humeral head.
That's right.
There is glenohumeral arthritis.
Yes, that's why I'm wondering. Yeah.
So this patient had a displaced fracture, which is the tuberosity is actually gone posteriorly and superiorly, right? And because there is an arthritic shoulder, the chance of healing of that fracture is lesser, because now the movement will happen at the head and the shaft junction, not at the head glenoid junction. So ideal candidate, I think, for a shoulder replacement or a reverse shoulder replacement. So what I was trying to get at is 2 things in this X-ray. Is that one, if you have any doubt about how that head looks or any problem, always go for a CT scan. Now there was a difference in consensus of opinion about needing a CT scan, the seniors or the teachers, Maheshwari and Dr. Pandey were saying there's no need to get a CT. We can always, go ahead with the humerus X-ray itself. And the younger ones like Shashank and Vivek are saying that we should get a CT scan. Now me and Raman, I think we're put in the center, and we go more and more towards the CT nowadays, because 80 to 90% of your decision making can change after a CT scan. So now my threshold from my UK days has gone down significantly to get a CT scan, not only for decision making, but to plan my approach of surgery, to plan where my sutures are going to go, to plan where my tuberosities are going to come, and to plan how I reduce the head. So that surgical planning is very, very useful from a CT scan, especially a 3D CT scan. If you can do a 3D CT scan yourself on a PAC system, is more useful.
Nandan, because you called me young, I'm giving you 2 more minutes.
And this is done.
And thank you.
I'm placing a nice, I'm giving a platform for Kapil to start.
Thank you for calling me senior and not old.
Okay, so we have...
Nobody is old.
Yeah, please carry on with your... let's not talk about the reverse right now, because let's leave that for Kapil. Let's go for your concluding slide, Nandan. Yeah.
No, this is the concluding slide. I'm just putting that this thing for Kapil to start.
Okay,
so that's
okay. Thank you.
Yeah.
Okay, so I think that's a very interesting, and I think one of the most interesting recent developments in the treatment of proximal humerus fractures besides the PROFA trial. Having an implant which can fix intramedular in an intramedular way takes away the medial cortical comminution problem, later on varus, and so on. The only problem I see, and Nandan, please indulge me on that. You said 2-part fractures. Most of the 2-part fractures are usually are not that displaced whether you need surgery. Some of them do. So the cases which actually require nailing in the practice of general orthopedic surgeons would be very less. So for them to get experience for a nailing in practice is rather difficult. So I want everybody to understand that. The most common is the 3-part fracture, where the GT is broken too. Now, when the GT is broken too, can you just quickly elaborate 1 or 2 points how to, because with that small incision, I would not be able to reduce the GT and be able to put the nail too.
Yes. So you can extend the incision distally, because this was a straightforward 2-part. We didn't have to open the whole, the proximal humerus to get a good view of what we're doing. But you can actually split the deltoid much more. Obviously, you should not extend beyond the 5 centimeter mark. If there is a GT fracture too, I personally, I've grown up seeing these nails from the last 20 years, and I have seen proximal humerus nails grew from a rush nail to this, but I still feel you're better off as a teaching point. I would stick it only for the 2-part fractures.
Okay, that's a very good point for everybody to note. Yes. Yeah.
I would not complicate yourself with using this for a 3-part and a 4-part and show that this can also be done. I think you can do that maybe after you put in 30, 40 of the nails in 2-part fractures and you know exactly what you're doing. Because the most important thing is that if you have a GT fracture, now the key in any nailing is you have to reduce the fracture to fix it. But once you have put the GT back, you can't see the head.
Yes.
So the window through which you are supposed to operate is not there. It is not like the proximal femur, proximal femur fracture, where we actually put it through the fracture site. Because if you do that, your GT is completely off and it is not going to heal. So that is the point. So my recommendation for anybody learning it is not to do it for 3-part and 4-part fractures.
A quick word from Dr. Maheshwari, because he also has done quite a few of them. Dr. Maheshwari, are you there?
Yeah, I think, okay. So big issue of fixing fractures is in elderly people with osteoporotic bones and comminution. Those are the patients where when you do plating, You don't know what is going to happen 3 weeks, 4 weeks down the line. And, we come to all this bone augmentation and blah, blah, blah. Those are the fractures which have given me a lot of peace of mind when I use a nail, because with the nail inside, it's a biomechanically such a good implant, technically quite difficult, I understand. But once the nail is in, I call it, do it, close the wound and forget about it. It's like that, fill it, shut it and forget it advertisement of one of the motorcycles. That's what I feel it is. Once I do a nailing in an elderly person of any kind, whatever combination, once the nail is in position, everything is fixed well, I don't have to look at that patient again, nothing happens. The whole bloody thing is so biomechanically stable that my biggest fear of fixing these fractures in elderly is late displacements. And then they end up in a chaos because they'll end up with nothing short of reverse replacement. So that is the window of use of these fractures. In everything else, you can do a plating. You can do a 2-part fracture plating in a young person. It'll give you as good a result as nailing. No issue. But in an elderly person, when osteoporosis is there, combination is there, you're always worried about collapse. And that is where nailing is my favorite implant today.
Deepthi, can I ask you a question?
Sure, Raman.
Deepthi, you said that 3 or 4 part you will avoid. And now this is what I am at the crossroads for nailing. I will probably choose a nail for a elderly patient with probably Parkinsonism. If the patient is not able to take care of himself or herself, I'll choose a nail. But 3 or 4 part, this is quite a contradiction to what the Pascal Bolo says. He designed his nail for 3 and 4 part fractures.
No, Raman, he did not say that he would not do it. He's saying for the people who are starting to do, it's better to do it in 2 parts. And because it is a PG class, he did not want to show the 3 or 4 parts.
Okay.
So people like you and Dr. Maheshwari can definitely go ahead and try your hand on a 3 part and a 4 part. It's like you going and doing percutaneous spinning.
Deepthi, I'm a plating man. I'll stick to my plate and fibula.
Okay. No, Shashank, one thing, it's a bit confusing here. Agreed, I fully understood when nailing's to be done and why it's done in osteoporotic fractures. But one small, the case Dr. Deepthi showed of the arthritic lady, and Dr. Maheshwari also commented that since it is arthritic, I would do a nailing. Sir, then what about this Proffer study? Now I'm going a little separate than away from nailing part. Now, could we have treated it conservatively? Now, this is a confusing statement because the Proffer says conservative, and this will do very well. Even Dr. Ramakant initially said, why not conservative? But at the same time, because it's arthritic, the movements will happen at the fracture side and not the joint. So there's a bit of confusion here. So could you just clarify now?
Yes, there is no confusion in that particular patient because if you have an arthritic joint next to a fracture, it may be in the hip, may it be anywhere else, what will happen? The chance of non-union is higher. So you are actually asking for a non-union and then treating the non-union. So the chance of you having a non-union in that particular situation is higher. That's the reason an arthroplasty was chosen.
So let me give you my patient for doing nailing there. Okay, this patient has lived with arthritic shoulder rest of her life. She has not come to you for arthritis. She has come to you for a fracture.
Dr. Maheshwari, I'm reminding you what you said. This is a PG class, not a shoulder meeting.
Okay, fine.
Okay. I think...
Shashank, I will remind you, there are young surgeons also listening,
So I think that's a valid comment and we can proceed.
Let's go to Dr. Kapil. Kapil is very patiently waiting, very silent. I don't know. Is everything, Kapil? Over to you.
Absolutely fine. I'm receiving and imbibing education.
It's probably too cold in glass.
The reason I haven't spoken about nailing is because I'm not a nailer. I'm not a percutaneous fixer. I don't have the skills of a Rash or a Pandey to be able to do percutaneous fixation. So I still plate or I still replace. I think nailing is a tool which is there. And I totally agree with Deepthi, 2-part fractures, pathological fractures is there where you could use it. But I think going beyond is off-piece skiing, and people need to be very careful, and that technique needs to come with a bit of warning. You need a lot of experience. It's like PG certification, for a film, it's got PG on it, please don't try it. So With that, and thanks Deepthi for laying out the nicely the platform to discuss arthroplasty. So I'm just going to share my screen, and while I'm doing that, Shashank's instructions were very, very clear. It is case-based discussion and nothing else. So what I have done is I put in a couple of cases for where we've done arthroplasty for proximal humeral fractures. I'm going to talk a little bit about technical nuances, and if you've got any little time, just talk a little bit about failure of hemiarthroplasty. So again, if somebody asks me what is the most difficult shoulder operation I do, my answer would be without any hesitation, it's a hemiarthroplasty for a fracture of the proximal humerus. In my book, that is the most difficult operation to learn and to get right. And why do I say that? I think a lot of people have already alluded to, whoever had that nice pictures with the anatomy of the various muscle pools and of the importance of the rotator cuff. So whatever implant you're doing, whatever you're doing, if you cannot get the tuberosities to heal, you can do whatever. You'll have either a dead bone or a piece of metal, but no function. It's interesting that we've had so many talks and we've had a lot of discussion about classification systems. And it is interesting that we still are talking about Mears classification. Mears classification, I think, had its time, but it should be allowed to drift away into sunset, in my opinion. It is a good descriptive classification, but there is so many caveats in it. And Dr. Maheshwari alluded to it earlier on. What is a two-part fracture? We have to be very careful. It's a centimeter displacement, 45 degrees angulation. So again, I see a lot of these 3-part, 4-part fractures, but it will be very clear. But it does not tell us anything about the prognosis. Hence, probably just for the younger surgeons out there, remember the Hurtle classification, because this is a prognostic classification. The key factor here is the association between the humeral head fragment and the two tuberosities. If that connection is lost, you are going to end up with a very high risk of avascular necrosis of your humeral head. And that is a big predictor on how you're going to treat these fractures. And from that Hurtle's classification comes the risk of head ischemia. And I have to talk about it because I'm talking about arthroplasty. We have decided that we are going to bend this humeral head. So when are we going to do that? When there's a very high risk of head ischemia. So either you've got an anatomical neck fracture, or you have got a fragment. So the medial hinge is disrupted. And the medial hinge is disrupted if you have got, there has been a paper which looked at that the disruption of medial hinge starts with about 3 millimeters of displacement. So even a minimally displaced fracture has got potential of disruption of medial hinge, and that is more in a varus fracture than in a valgus impacted fracture. That is why valgus impacted fractures do slightly better, and that's what the work from Court Brown from Edinburgh looked at, and valgus impacted fractures got a better prognosis in terms of AVN because the medial hinge is preserved. So we have to be very mindful of this and what classification you're using. Is it a descriptive but also a prognostic classification? The other thing which you have to look, whatever imaging modality we use, Samir told us about X-rays, various views, use of CT scans. But when you're evaluating a fracture, apart from looking at the fracture pattern, please do look at this metaphyseal spike of the medial fragment. If this is more than 8 millimeters, more than 9 millimeters, there is blood supply getting into this humeral head. If this spike is not there, then your blood supply is not getting to the humeral head. So with that, I'll just start this with this case. So this is a 65-year-old, reasonably fit and well lady who's got no significant comorbidities, who's had a fall while walking outside, and she comes to us with this. Now, I'm braced for criticism because I've just shown you one X-ray, but I promise you, the only reason I haven't put the other views is that I don't have those views on file, and I could not locate them to find the other views or a CT scan. But you can see, now, if you were using the Mears classification, this is a 4-part fracture. You've got a head fragment, you've got a greater tuberosity fragment, and you've got a lesser tuberosity fragment. But more importantly, if you're using Hurtle's criteria, this metaphyseal spike is not there. It is less than 8 millimeters. I think the medial hinge is gone, although it's a valgus fracture, but the medial hinge is gone because the fracture is displaced and there is significant valgus tilt of the humeral head. And there may be further split. Again, as I said, I don't have other imaging to show you. So to me, this head looks, we may be, somebody as skilled as Raman will probably go and fix it and get a beautiful X-ray, but will we get reasonably good function and will this head survive? That is the bottom line. And at the age of 65, can you afford to do something else apart from fixation where you know there is a high risk of vascular necrosis? So what are the technical issues with this patient? Or how are we going to treat her? You can treat her non-operatively. You could, Prophet trial will tell you that if you're in surgical equipoise, or you can't make up your mind, you can leave it as it is. But you've got a patient who is fit and well, and as Dr. Maheshwari said, has not come to you with any other pathology, but the shoulder was functioning well, and now she's fractured it. Can you fix it, or do you replace it? The problem with fixation here is the inadequate bone stock in the humeral head and a high risk of AVN. Of course, when you are going to discuss, think about your decision making, you're going to take all these levels, all these factors into consideration. Now, this lady is really active. 65, she is young. In the UK, average life expectancy for a woman is in high 80s. So she's got more than 20 years to live. Will she comply with my rehab? Yes, she will. She is pretty good. But she has got a risk of AVN because of the fracture fragment. So this is my decision-making algorithm which I'm going through. What is my patient? What is the fracture? And as Dr. Pandey and Deepthi have said, right patient, right surgeon, right treatment. And that's what gives you, that is how you get it right the first time. So I decided to go for a hemiarthroplasty. And when I have discussed the second case, we will tease out the arguments for doing a reverse or a hemi. So if you've decided to do a hemiarthroplasty, what are your challenges? Your challenge, as I said, it is the most difficult operation in my book because you've got so many things to consider. You have to get the height of the tuberosity right. You have to get the offset and the version right. You have to get the tuberosities in the right place so that they can heal to each other and to the shaft. And they also have to stick to the, whatever metal you put in there, they have to stick to that as well. And then they should not impinge to get your range of motion. So you can imagine, you can see that there is so many different factors or so many dots have to line up so that you can get a perfect picture here. So I'm just going to go over some issues with which I'm sure a lot of trainees would have encountered, and probably people who don't do hemiarthroplasty on a routine basis would have encountered as well. Mind you, you're not doing a hemiarthroplasty for an intracapsular fracture of the neck of femur. That's a completely different thing. Think of this as doing a total hip replacement if you're a lower limb surgeon for a 4-part fracture of the proximal femur. It is difficult, okay? So this is difficult as well. So how do we get the height right? Now, in a lot of patients, you will see that this medial calcar fragment will be intact. And this is, again, your preoperative imaging, which Samir told us very nicely. This is how you plan, and Deepthi alluded to about planning your treatment. So this is what allows you to see how big is that spike. If you've got the medial calcar fragment intact, great. That is your landmark. Then you have to look at then you can use the pec major tendon. So from the top of the pec major tendon to the top of the prosthesis here is about 43 millimeters. So again, you can use that as a reference guide. As regards your version, your bicipital groove gives you an indication of how to get your version right. Okay? So this is a surgical exposure now. I use the deltopectoral approach. I find it much easier because I do all my arthroplasty through that. I do it through the deltopectoral approach. Can you do it through the deltoid split approach? Yes, you can. It probably offers you a very good view. But I just find because I do all my surgery through deltopectoral approach, I use it. And moreover, because I do a lot of revision surgery, again, I stick to one approach. So I've told you about how to get the prosthesis right, but that is the smallest part of the operation. The most important and critical part of the operation, as Dr. Maheshwari has said throughout this afternoon, is to get the tuberosities around. So this tuberosity envelope has to close around the prosthesis so that you are restoring the cuff function, you're giving the soft tissue envelope around the prosthesis, and it gives the tuberosity the best chance to heal. So this is the soft tissue procedure. The metallic insertion of the metal is the easiest part. It is getting this right. So you spend a lot of time, you mark both your tuberosities, the greater and the lesser, with non-absorbable thick sutures. I use fiber wire, you can use Ethibond. You fix the tuberosities to the shaft, so you pre-drill these holes before you implant your prosthesis. And so 2 holes medial to the bicipital groove and 2 holes lateral to the bicipital groove. You pass the sutures through it, and then I run a circumferential suture around both the tuberosities, going posteriorly and around. And just a little tip for, sometimes it may be difficult to pass the suture. I use a loop PDS, that comes with a large blunt needle, and you pass it from the medial side, go around the prosthesis, and come through the posterior cuff here. And through that, I now use fiber tape. You can use other heavy suture, and this is what you should get at the end. It looks like as if you've got sutures all over, but that is what you need to do, is to get your tuberosities down and healed, giving them the best chance to heal to the shaft and to each other. So this is the case that I showed you earlier on. So we did a hemiarthroplasty. The stem has to be cemented. In my book, a fractured hemiarthroplasty has to be cemented. And you can ask me why. The reason is you're dealing with osteoporotic bone. To get a good hold on that, and so that during your implantation, your stem doesn't change its position, you must cement your stem. I use a very modular system where I've got a diaphyseal fragment component which goes in, and then I can put in the metaphyseal component, which is coated, porous coated, and I put a bit of bone graft underneath it, and you can see my tuberosity is sitting underneath the top of the humeral head. And Shashank mentioned something else in relation to something else, that your tuberosity has to be below the highest part of the humeral head, otherwise it will impinge. And you can see that the Gothic arch has been restored. And when you look at the lateral view, that's the tuberosity, greater tuberosity right down in its position, and you can see a sort of a normal humeral head. So this is what an ideal hemiarthroplasty should look like. But is it going to heal? That is a big question. And we know that up to about 40% of greater tuberosities do escape after a hemiarthroplasty for fracture. So again, results are not great, but in somebody who's 65, you really don't want to put in a reverse arthroplasty, and we'll discuss the reasons in a second. So that brings me to my second case, which is a 76-year-old lady who had a fall at home. She is otherwise reasonably okay, hypertension, ischemic heart disease, but all well controlled. So in this case, we did do a CT scan, and you can see she's got a fracture dislocation of the shoulder, the very comminuted tuberosity, the head fragment is small sitting there, and you can see the coronal images of her scan as well. So, the management options are always the same.
Kapil, may I interrupt you?
Please, yes.
So, the first X-ray, and this is a 76-year-old female, I think. It would have been, you wouldn't have reconstructed anyway. Why did you get a CT scan done in this patient?
Yeah, good point. So in our unit, if the patient comes out of hours and the trainees see this fragment, they will get a CT scan.
If she would have come to you straight away, would you?
No, I won't.
Okay.
For me, it's clear. You know, I would get two views, but it's very clear. This is not reconstructible at the age of 76.
Right. Okay.
Okay.
Yeah. Sorry. Please carry on.
Yeah. Sorry. So, is it non-operative treatment? Unless there are very serious contraindication to surgery, you know, I don't think there is non-operative treatment is an option here. The head is sitting in the axilla here. It's very close to neurovascular structures. He doesn't have a neurovascular compromise now, but I don't think you can afford to leave it there. Fixation, again, in my hand, I think the fixation is going to fail because of the poor bone stock. Although interestingly, I'm sure the astute observers would have picked up that she's got a big metaphyseal spike here. So according to Hurdle criteria, this is not that bad. But on the other hand, the humeral head is dislocated, and it's a very small bony fragment of the humeral head. So again, I don't think this is reconstructible, at least in my hands. But even if you were able to get a good X-ray, I don't think you will get an eventually good function because this head is going to collapse and you will end up with AVN and metalwork all over the place. So arthroplasty is your option now. Now, the issue with arthroplasty, as we discussed before as well, with a hemiarthroplasty, the success is in the healing of the tuberosities and, of course, correct positioning of the metalwork. So let's say even in best hands that you're the best surgeon, you get everything right, the tuberosities may or may not heal. And if you're going to do a hemiarthroplasty, I'm not brave enough to get them mobilizing at the end of week 1 because I'm relying on my tuberosity to heal back. So the patient has to have has to comply with the rehab, and it's a longer rehab with hemiarthroplasty. So in my book, I'm going to treat this patient as a primary cuff deficient shoulder now, and I will do a reverse arthroplasty. Okay. And again, these are the considerations which we put up before as well. So you've gone through those, you've realized that this is not reconstructible, so you're going to do an arthroplasty. Okay, we've discussed this. So now this is what I have done. But the whole thing is not about what I have done, but the question is how do you get there and what is your decision making? And once you've decided to do a reverse arthroplasty, what are the chances, what will you do technically to get a good outcome? And I think that's what people need to understand. First, a word of caution, this is surgery not for the beginner surgeon. I think you need to have done a fair amount of reverse arthroplasty for arthritis before you start doing fracture. Because again, remember, you don't have a soft tissue envelope around it. So there is a higher risk of instability, there's a high risk of infection. And again, those things are because of the position of your implant and again, your tuberosities. Now, a lot of trainees ask this question saying, well, this is a cuff deficient shoulder. Why do you really bother putting the tuberosities back? As you can see, I have brought the greater tuberosity back. I have restored the medial calcar. And again, I've gone through the same thing about suturing these tuberosities together and to the prosthesis. The reason I'm doing this is twofold. One is to get the soft tissue tension right. Number two, to get a good soft tissue envelope around the prosthesis, which contributes to the stability. But lastly, if you don't have the tuberosities attached, you do not have any rotation because you don't have any cuff function. You don't have the lateral rotators to give you lateral rotation. If they don't have lateral rotation, their eventual range of motion and function is affected. So it's again very important to bring the tuberosities down and to repair them exactly like how we did in a hemiarthroplasty. So just what implant you use is, of course, what you're trained with, what your experience is, and what is available locally. But I find I use this implant that which has got a diaphyseal component, which I cement in. And then I've got the option of either pushing a metaphyseal reverse body or a metaphyseal anatomical hemi. And then I can put a appropriate bearing surface afterwards. But the key that again want to emphasize is that in my book, and others may disagree, there is no room for a cemented implant in a fracture case. Whatever you're doing, hemiarthroplasty or reverse, there is no room for a fracture. You must always cement your diaphyseal component. Okay, and again, tuberosities are the key. So in this case, you can see I'm using a cable system to secure the tuberosities. So again, you've got sutures coming from the two tuberosities, not through the tuberosities, but through the cuff, so subscapularis and the posterior cuff. And then you've got a circumferential cable going around. Now, this picture is interesting. If you look here, some part of the supraspinatus is missing. And I know that a lot of surgeons, if the supraspinatus is intact, they actually cut it because they believe that it restricts the range of motion. I've never done it. I have repaired all the tuberosities back, and I haven't regretted doing that. And we can discuss that later on. So why do you get the tuberosities? As I said earlier on, it's for stability. It's for giving you improving the range of motion, especially the rotational movements. Okay. And this is a lady who's had a reverse shoulder arthroplasty on her right side. This is not the same patient I showed you earlier on, who's got reasonably good function. She's quite happy. And the advantage of doing a reverse shoulder arthroplasty in the older group of patients is that although you have to bring the tuberosities, but you're not relying on ultimate function with a tuberosity healing. The other thing is the rehab is much quicker and they get better function. Can I just, Shashank, I just need to take a pause. I'm going to call for the hospital. I'm just going to mute myself for a second.
Sure. In the meantime, we can take questions. Are there any questions?
Yeah. Sorry, I missed the call. Okay, no, forget it. I'll call them back later. Okay. So, yeah.
You can ask that lady to stop.
Yeah, she stopped. So the key to success for arthroplasty is patient selection, cement your stem, whatever you're doing, suture the tuberosities. Remember to get the height of the prosthesis right and the version. Now, the version is obviously different. In a hemiarthroplasty, you're going to go with about 30, 35 degrees of retroversion or whatever is normal for the patient. And in a reverse, I go about 10 degrees of retroversion. I know people put it in neutral, but the version is different. So that is the arthroplasty. Now, as we have discussed, if you've decided to treat your fracture surgically, try and fix most fractures. If you're doing hemiarthroplasty, consider that as a soft tissue procedure to reattach the cuff and tuberosities. And as I said, version, height, and tuberosity are the tuberosity healing is the key to success. And this is my algorithm. So try and fix it. If not, then if in the younger patient, do a hemi and tuberosity is good. If tuberosities are poor and they are older, then you do a reverse. There is some evidence in the literature which says that in the elderly patient, the reverse is definitely better than a hemi. And just, if you can indulge me for a second, as I said, all hemiarthroplasties don't work. So this is a 72-year-old lady who came to see me 2 years post hemiarthroplasty, the same system, done in a hospital by another surgeon. And she said to me, very interestingly, she had never felt the shoulder to be right after the operation. And she had pain and poor range of motion. After excluding infection and everything else, I decided to revise it. And the revision with this system was very easy. It's the easiest revision I've ever done, 45 minutes. You take the metaphyseal component off, leave the diaphyseal component in, put in the glenoid, screw in the metaphyseal component of the reverse, and that's the revision done. I think some people might find this odd to look at, but the revision, you can't see the glenosphere because this is a system in which the glenosphere is poly and you've got metal on the humeral side. Thank you.
Thank you, Kapil.
Can I Shashank, ask?
Samir, yes, please carry on.
Okay, Dr. Kapil, how do you decide in a case where you decide the patient is going to get replacement, hemi or reverse? When do you decide when to do reverse? I mean, how do you know whether the cuff is intact or, I mean, cuff must be the differentiating criteria. Do you get an MRI done or how do you decide? Between hemi and a total, I mean, reverse shoulder.
So the very blunt tool is age, okay? And the other thing is that over the last 5 years, I was looking through my records. I've done one hemiarthroplasty for proximal humerus, while I've done tens of reverses of fractures. And the reason is that in the slightly younger patient, I will try and fix it. I'll try my hardest to fix it. And if I cannot replace then my preference is to do a reverse for the very simple reason that a hemiarthroplasty is like a lottery. Your results of a hemiarthroplasty are like a lottery because there are so many things that can go wrong. You can do the best operation and the tuberosity will escape. The lady I showed you the revision case that I did, my colleague did a very good operation. The tuberosity was at the right place, but it had escaped and it failed. So for me, if you ask me, the other question is to when I do a hemiarthroplasty now, my hemiarthroplasty is done in the younger patient. When I say younger than 70, where I have no chance of being able to fix the fracture. Then in that case, I will do a hemiarthroplasty. In the over 70s, there's no question at all. If they've got a displaced fracture, which I don't think we'll be able to fix, we'll go straight for a reverse.
So would it be fair to say that between 60 and 70, if we tilt towards somebody or maybe anybody tilts more towards reverse, would be a fair thing to do?
Yeah.
Than a hemi?
Yes.
In Indian age group, yeah, you would be right. Yeah.
It will be, but again, I don't want to give the wrong message to people. People think reverse is a very easy operation because you can get away with a lot of things, but when things go wrong, instability is the biggest thing in a fracture case which has not been done properly. So yes, it is a difficult operation, but if I had to choose between one or the other, I would probably err towards doing a reverse than a hemi.
In an expert hand, and that's about
okay. So that is a very important point he made. Reverse in best of the hands in proximal humerus fractures has the worst results of all the other cases. So please don't think doing reverse is an easy thing to do. If I can't fix it, let's do a reverse. The most of the failures, almost 70% of all the, if you combine the registry of all the reverse arthroplasties, 70 to 80% of failures are actually in proximal humerus fractures, which is the primary indication of reverse in India. We are not doing reverse actually mostly in arthropathy. They are the patients who give the best results. So if you take the cream results of reverse arthroplasty across the world, the best results are only in the arthropathy, where we are not doing it. And the worst results are the proximal humerus fractures, where we are mostly doing it. And that's why reverse is actually getting a lot of bad name, because these give bad results anyway across the world. On top of that, these reverse are being done by surgeons who don't have at least 15, 20, 30 reverses under their belt in the normal regular cases. So the results are actually going to be bad. And that's exactly what Kapil was trying to allude to. Any other comment from the Kapil wants to say something?
I'm going to say something. You know, it is interesting, Shashank, that when people do a reverse for a fracture, they get great exposure of the glenoid because everything is gone. But the problem is not putting the glenosphere in. The problem is getting the height of your and the soft tissue tension right. And that is why it's very important that people should pay attention to the tuberosis and deal with as a thing of getting the tuberosity in the right place. And then when you do that, you will understand that your humeral component is in the right orientation. I have revised reverses where the humerus was in about 45 degrees of retroversion, which was unstable. So, you know, there is a huge thing about that.
Any other comment from the faculty? Okay. No, Dr. Maheshwari, you want to say anything?
No, okay. I think you can summarize. It's already 8:30.
Okay, so we'll just summarize quickly in next 5 minutes the salient points made by all the good speakers we had. We started with Samir, who talked about X-rays and CT evaluation of the proximal humerus. You need to have two views of the proximal humerus, two mutually perpendicular views, not two views of the shaft, two views of the proximal humerus. As Dr. Maheshwari pointed out, make sure that the AP view of the shoulder of the proximal humerus is done in neutral rotation, not in the sling. Usually these patients are in the sling, they are painful, they resist getting into the neutral rotation, but try to get your AP view in neutral rotation. And if possible, should be done standing. That was followed by Vivek, who touched upon the conservative treatment. And the most important point in his talk was, if you are treating these patients conservatively, get serial X-rays done. And how to decide where to go conservative is if you can see the head in front of the glenoid, not in one view, in both the views, AP, Y view, axillary view, CT scan, whatever you have, but head should be in front of the glenoid in both the views, and GT should be below the head. And the head and shaft should be by and large in a straight line, not much of angulation in lateral view. One important point he made was axillary nerve. Please make sure, many times we miss, all our attention is on the bones, what we see on the x-rays. Please look for the axillary nerve and document it if you cannot. Sometimes patients are in pain, you cannot see obviously you cannot do abduction, but if you cannot make out, if you cannot document, just write down that axillary nerve could not be assessed. That was followed by Dr. Pandey, who talked about PC pinning. Again, he touched about axillary and nerve injury, but beyond that, he said posterior dislocation is often missed. Make sure that you have a good lateral view and a Y view or a CT scan so that the posterior dislocation is not missed. Please, in every proximal humerus fractures you come across from now, look for axillary nerve injury and posterior dislocation. Rule them out, then go ahead. The PHs are basically soft tissue injuries. Try to reconstruct the soft tissues, the rotator cuff around the head of the humerus. And if you can do it with minimal metal work, like Dr. Pandey or Dr. Maheshwari does, very good. When you're putting those wires or screws, the first one should go from GT to calcar. Now, most of us, we do it, our usually first pin goes from the shaft to the head, upwards. Your first screw should go from GT to calcar, and that's what Dr. Pandey talked about. Then we went on to Raman, who showed some beautiful cases. But the point he made was plating is just a means to end to reconstruct the GT. Plate is not to fix the head to the shaft. The plate is there to support, buttress the fracture, but mainly to get the GT to unite to the shaft. So those holes that you have there are not merely for the screws, they are for the sutures so that you can reconstruct the tuberosities with them. And even if you get AVN, as he showed, you can still have good function, but the GT must heal, so focus on GT. Then Nandan talk about nailing. Please don't be adventurous. Try to do it only in two-part surgical neck fractures. They're actually godsend in osteoporotic fractures, in patients above 60, 65, two-part fractures. As Dr. Maheshwari said, fill it, shut it, forget it. Just put the nail in the proper position, and then you can start mobilizing from the third day. No problem, just simple pendulum exercises. Yes, you must ensure good reduction before you start fixing, as Nandan said. Confirm it in both views, otherwise you might get into trouble. And lastly, it was Kapil. The most important point, hemiarthroplasty of the humerus is not the same as the neck of the femur. Now imagine you are doing a hemiarthroplasty with the GT or greater trochanter broken. It's very difficult to get the soft tissue balance there. So the proximal humerus fracture is akin to that, not the fractured neck of femur. So hemiarthroplasty, as he said, is a very, very difficult operation. Please don't take it lightly. And if you think there are high chances of AVN, go for replacement. Hemi, as he said, very rarely. Try to fix it as much as you can. And if the patient is above 65 or 70, replace. Again, there also tuberosity healing is the key. Tuberosity healing is the key across the board, whether you're doing pinning, you're doing conservative, you're doing plating, hemi, or reverse. And the last point, reverse arthroplasty in proximal humerus fractures should be attempted only after you have done a few regular ones. As we just said, the results in proximal humerus fractures are rather bad. There are high chances of infection. There are high chances of instability. And whenever you are fixing it, fix it with a cemented stem. Dr. Maheshwari, did I miss anything?
No, I think it's quite all right. Do we have any questions on the chat box?
I will stop sharing.
I can see some here. and they're...
There is, Dr. Maheshwari, there's one about displaced GT fractures with ipsilateral neurological injury. And I think the message that we have, so in the UK, we don't fix the neurological injuries, it's the nerve special, there is a special nerve injury service. But if you've got a displaced GT, so the most common scenarios, you've got a fractured dislocation of the shoulder with an axillary nerve palsy. So the advice is that you should fix the GT fragment early, because a lot of low energy axillary nerve injuries will improve. But even if you will not explore or repair them for about at least 6 weeks, and in that case, your GT fragment may become inoperable. So the message is that you should try and fix them early, and you can deal with the nerve injuries at a later stage. So unless there is other views which are contrary to this, but this is what the advice that I would give.
One doctor, is there any other advice? Because there's one more question I can take after that. Okay, so Dr. Sandeep Chaudhary has asked that why does the X-ray shows subluxation but not in a CT scan? I don't know. I am not exactly understanding this question, but
that's in a post-op X-ray. That's a post-op scenario.
Okay, in a post-op, can you Lalit, can you explain his question?
At times, when we take a post-op X-ray after maybe fixing with a plate or something, you see a subtle subluxation of the joint. However, when you try and confirm it with a CT, it comes out to be okay.
You mean posterior subluxation or inferior subluxation?
Inferior.
Oh, inferior subluxation is rather common because of the deltoid atrophy, and that usually corrects as the patient starts mobilizing. But was he talking about inferior subluxation?
Yeah.
Okay.
Because when the patient is lying down, the gravity is not acting and is not pulling the limb down because of axillary nerve palsy and deltoid atony. In a CT, patient is lying down.
I'm sorry, I didn't get that.
He's trying to explain the mechanics behind it.
Okay. Same thing. The gravity pulling it down, the whole shoulder down. Yeah.
Okay. Any other questions, Lalit?
I can't see any. So, unless the faculty wants to give a parting comment, one parting comment.
Dr. Maheshwari?
Well, I think we discussed this on our group. The general orthopedic surgeon has to understand that there is a Lakshman Rekha to treating these fractures. We as orthopedic surgeons think fracture treatment is our bread and butter, which is perfectly all right. But particularly in shoulder fractures, and also in the hip and also in the knee, but particularly in shoulder fracture, because it's a very funny fracture to get functions right, because there is hardly any bony security, the kind you have in the hip, in the knee, exposure-wise, experience-wise. So I think there is a Lakshman Rekha every orthopedic surgeon must draw, that beyond this, he should not play around with this humerus fractures. I remember one of the X-rays shown by somebody where a dislocated X-ray was, percutaneous pinning was done.
It was an open pinning.
That was criminal.
I know.
So basically, I mean, we should know what is our Lakshman Rekha, because treatment varies from conservative to reverse shoulder replacement. I'm sure till conservative plating, little bit nailing, little bit, this is okay for everybody. But as soon as you realize after doing these CMEs that some of these fractures are actually beyond this, it is better to refer them, because first treatment is the best treatment. Once the surgeon has gone in, then to revise that case is horrible for any surgeon, because the tissues are gone, they have removed every tissue, you don't know what. So ultimately, even in a young patient, sometimes you'll end up doing something like reverse, because everything has been messed up by the previous surgery. So I think Lakshman Rekha has to be remembered, particularly in a humerus fracture, because disasters are just too much. The whole limb becomes dysfunctional. If you can't lift your shoulder, your elbow is gone, your hand is gone, you're totally disabled. So I think I would like to highlight that point. Know your limitation as a surgeon and draw a Lakshman Rekha on what you will not do.
Lalit, over to you.
Thanks, Shashank, and I think a very great evening. Nice X-rays and a lot of discussion generated. Really thankful to all the faculty, Kapil and Pandey. Pandey had to leave early, and Nandan and Vivek, and also our own Delhi Orthopaedic Association group, Samir and Raman. And of course, the anchor and the guide of shoulder surgery in this part of the country, Dr. Maheshwari, has really added value to today's discussion. And Shashank, thanks for anchoring it so well. And we had a delegate number around 1,200. So that's very heartening. And our next weekend is slightly free in the way that we don't have a DOA event. We are academic partners to a biomechanics event, which is being done by Indian Spinal Injury. So you can go to their website and look at it. It's a very, very nice program they have charted out. And we would meet again on the next Sunday, which is the second quarterly meeting. So thanks a lot to everybody, and good evening and good night. Stay safe. Thank you.
Bye, everybody.
Thank you everyone. Thanks Shashank, Maheshwari sir, and Dr. Lalit sir. It was fantastic. Very enjoyable. Learned a lot. Thanks.